Uganda, the movement of men through warehouses and
Good morning. Good morning. Welcome, Gerald. We'll be starting in 5 minutes. So in 5 minutes, I can see everyone is here. We should start.
Good morning. Small announcement. The owner of this vehicle, the number plate UBH 746Y, kindly attend to your car. Thank you.
Moses. Good morning. Allow me to start. Allow me to start this meeting because we have some virtual participants that have already joined. I would also like to request that I can take my mask off since I'm socially distanced from everyone by a number of meters. I'll put it on as soon as I'm done. So good morning, hello, and welcome to the Health Supply Chain Innovation Pitch event. This event is a platform that allows us to listen to local and innovative solutions that could impact Uganda's health supply chain. The goal of the event today is to select 3 innovations that will be supported technically and financially to pilot, test, scale, and it's a great opportunity that we're here today to listen to these innovations. I would like to thank everyone that has joined and come here physically and all those that have joined virtually. Would like to recognize the presence of the Ministry of Health, Director General of Health Services, Dr. Henry Mendasa. Thank you for honoring us and for being here with us physically. From Ministry of Health, we also have the Commissioner, Department of Pharmaceuticals and Natural Medicines, Ms. Neville Okuna-Oteba. Thank you for joining us. We also have the Assistant Commissioner, Division of Health Information, Paul Mbaka. Thank you for joining. With us today, we also have USAID, represented by the assistant, represented by the AOR, Mr. Noah Kafumbe. Thank you for joining us. We have the Executive Director of Uganda Healthcare Federation, Ms. Grace Kiwanuka. Thank you for being here with us. We have representation from National Medical Stores, Mr. Paul Okware. Thank you for joining. And all the distinguished guests that are here with us physically. For those that are with us virtually, we shall recognize your presence as the names are shared, but you're all welcome, and we recognize all the distinguished guests in their capacities wherever they are. Thank you for honoring us today and sparing time to be at this speech event. My name is Belinda Blick. I'm the Stakeholder Engagement and Innovation Coordinator at the USAID Strengthening Supply Chain Systems activity. Because it's a public event, we'd like you to go onto our social media platforms and create visibility for the innovation teams that are here with us today. Please use the hashtag #SSCS_Challenge_UG. We'd also love to hear your questions and comments. So you can use your personal YouTube accounts and go into the YouTube chat and post your comments and questions there. We'll take 2 questions that will be answered during the Q&A session. And then we'll also have some clarifications or questions from the judges just after the innovation teams have presented. For those that do not know about the USAID-SSCS activity, it's a 5-year project implemented by the Management Sciences for Health in collaboration with the Advocates Coalition for Development and Environment and the Uganda Healthcare Federation. This activity supports Uganda's efforts to strengthen its health supply chain, to increase availability and access of safe, quality assured essential medicines and health supplies at the health facilities. Some of the interventions we have in place are looking at living in place self-sustaining, responsive, innovative interventions that will strengthen, that will allow for uninterrupted, accountable, essential medicines that are delivered to the health facilities. One of the interventions we put in place is the Innovation Lab. This is an approach or a concept that was conceived to allow us to engage, collaborate with typically non-traditional supply chain actors to come up with innovations that could resolve our health supply chain challenges. We put in place an approach, an open approach that stimulates innovations both internally and externally. For the external participation, we put out Uganda's first health supply chain solutions challenge that was launched for a period of 1 month. This initiative was launched in collaboration with UNFPA and Outbox. Would love to appreciate the support that UNFPA and Outbox have given us to leverage on the experience of the Innovation Lab and use of the platforms, the App Accelerate platform. This partnership was made possible by a gentleman called Cedric Anil Mohebwa, who worked at UNFPA and was passionate about social innovations. Unfortunately, so Cedric lost his life, lost the battle to COVID. May his soul rest in peace. Following the call that was put out, the innovation call, we received 136 applications. To select innovations that would advance to the next level, we used the following criteria. 1, the criteria looked at the ability for these solutions to solve the problems within the health supply chain space. We also looked at, we supported, and this was done, we looked at solutions that could integrate within the existing health supply chain systems. We looked at solutions that were innovative in terms of a differentiated approach that they bring in comparison to what is already existing. solutions that were efficient, based on quality, time, cost to implement successfully, but also effective in terms of impact in the short, medium, and long term. We also looked at solutions that could increase community level of awareness to demand and account for supply chain services. This led us to select 10 most promising solutions that were identified and advanced to the bootcamp. The bootcamp is that platform that allowed us to co-create with the innovators. We were able to support them, refine their problem statement. We supported them to realign their innovations to the national supply chain priorities, the USAID COP21 supply chain priorities, and the SSCS goals. We also had mentorships that were there, mentors who came with subject matter expert and provided the health supply chain context. We supported them to improve their pitches, but also had allowed them to speed date. This was a chance for them to listen to other innovation teams and find and identify if they could find potential mergers. So today, we're going to listen to 9 innovations because we have 2 teams that actually merged from the 10. 9 innovations. Today, we'll also select 3 winning innovation teams that will be supported technically and financially to pilot, test, and scale. As you listen to the innovations today, you'll realize there are 2 groups. There are innovations that are at the ideation stage. It's still an idea and we need to nurture it, pilot and test it. We also have innovations that have been implemented for a period of 1 year and so need to be scaled. So they're exciting innovations that you're going to listen to and would like, and I know I'm excited about them and I hope you will be excited about them too. In the next short while, I'll take you through the agenda, today's agenda. And next, the agenda. Yes. So in a few minutes, we'll have Dr. Eric Lugada, the Chief of Party of the USAID-SSCS activity, come in to give his welcome remarks on the journey so far. Dr. Eric will then invite the next distinguished guest. We'll have remarks from UNFPA, the assistant representative. He'll also introduce the Director General, Health Services, Ministry of Health, to give opening remarks and the official opening of this event. Moses Mukundane will introduce the judges, and the next half of the event will be moderated by Outbox, who will moderate the pitches and the selection of support the judges during the selection of the innovation teams. As we come to the end, we'll have announcements of the innovation, the winning innovations, and we'll have closing remarks from the Commissioner, Department of Pharmaceuticals and Natural Medicines. This event should end by 1:30. So thank you very much for listening to me. I would like to now welcome Dr. Eric Lugada to give his welcome remarks. Thank you very much.
In the meantime, welcome, ladies and
Information
gentlemen.
sharing between the health center.
Welcome. In the meantime, you're all welcome today. We're so glad to see everybody here, and we are so excited. The Director General, Minister of Health, we are so honored to have you here. Madam Neville Oteba, Commissioner for Pharmaceutical Services, welcome. Noah from USAID. The American people do give us all the support, and we are fortunate enough to be represented by our agreement officer who represents this program to the USAID. You're most welcome. And on behalf of the American people, we want to send our gratitude to them through you, sir. Our partners, ACORD, UHF, Mr. Paul Mbaka, the head of the Directorate of HI Division of Health Informatics, Ministry of Health, welcome. Our judges, you are all welcome. My colleagues, staff at MSH, and more importantly, the innovators. We are fortunate enough to have these innovators, people from the community, from the public. As they pull up the slide, I'll just expand the reason why we're here today. We know that healthcare is not just a responsibility of the Ministry of Health or the responsibility of health workers like ourselves. It is our own responsibility. You can actually, most of the diseases we have in Africa can be prevented through health promotion and health prevention. If you did health promotion and prevention, then you don't need to end up, sorry, I have feedback. You don't need to be in a hospital. In fact, hospitals are not supposed to be part and parcel of the like day-to-day running of a healthcare system in any country. Hospitals are curative, and by the time you're sick, it is too late. If we emphasize health promotion and health prevention, we would probably need very limited access, or we will have a very limited need for hospitals. And it's time for us to begin as a nation, as a country, to focus on health promotion and health prevention so that we don't end up in the hospitals. Because if you end up in the hospitals, there are only two options. From the experience we've had from the COVID, if you get COVID, you'll either die, you'll be very sick, you could get well, but the option of dying is also imminent. So if you go to the hospital, you're exposing yourself to the possibility of dying. And yet you can prevent such a possibility occurring. So as we move forward, I think our program is funded by the USAID from the American people. Essentially, it's strengthening supply chain systems in Uganda. The support from the American people started over 10 years ago, and now we are gearing to the finale. For the last 10 years, MSH, with funding from the American people, we've been supporting service delivery, which is associated with supply chain. They have funded the elements which started with the care and treatment of HIV-infected patients and associated symptoms. So the US government has been supporting, among other development partners, the purchase of HIV commodities, the training of health workers in the management of HIV-infected individuals. They purchased motorcycles to move and avail the services to the community, because the US government proposed, rightly so, that we need to reach where the patients are. So all the structures and systems which have enabled us to reach HIV-infected patients in the community, differentiated service delivery, have all been supported in part by the US government, American people. As we move 10 years later, one of the tenets we focus on is sustainability. What is it that we need to be doing now to get the sustainability? Slide one, please. So the purpose is that we should work ourselves out of a job as technical advisors. And right now, we're in that phase where we're working ourselves out of a job. We, and myself, plus my colleagues, we work for Medicine Sciences for Health, MSH. It's a global organization which supports, it's a nonprofit, supports governments, civil society, the private sector, and healthcare workers to build resilient and sustainable health systems. We are geared towards saving lives and improving health in the community, and we principally bring to bear practice into public health, the knowledge we know for disease prevention, and translating it directly into public health. How we work is through a few things. The first thing we emphasize is we are supporting the whole country or the whole world and the countries where we are to achieve the United Nations Sustainable Development Goals. And most of these Sustainable Development Goals are geared towards well-being and health, particularly Sustainable Development Goal 3, which looks at well-being and health for all people of all ages, in all situations, principally measuring at the reduction in infant mortality. So that's a critical point that MSH focuses on. The second thing we do is we look at empowering communities to do. I'm trying to wait for my slides. I'm off. Where's the next slide, please? Gerard. We support communities to locally lead. We partner for local leadership. Local leadership, it means we do not change. We expect people to innovate. We develop what they have developed and support them to implement so that they are in charge of their own development as well as taking charge of their own health. And an example of that is how MSH is working on behalf of the Ministry of Health. We do not replace the Ministry of Health, and we are instructed by the American people to support the government of Uganda. So we're here and we plug into the national system itself. We don't develop parallel systems. And another example is the innovators we have here today. We ask them to innovate in addressing the gaps that we have in healthcare. And it's their own initiative. Now we want to bring to bear the dreams they have in order to support solving the healthcare challenges of this country. Gerard, please. Sorry. Second, MSH believes in innovations, and this has been typified by today. We believe strongly that we can help through innovation improve the existing health systems to adapt to the complexities and changes in the world. Currently, we started off with paper-based systems. We're going digital. If you went digital, you can improve the way healthcare is delivered. And now part of the innovation is to support these new initiatives to ensure that we support. The other thing that we do as MSH, we look at the holistic system. WHO defines healthcare as the absence of disease, both physically, emotionally, economically, in the environment and everything. And that system approach, because all systems affect health. Health does not stand alone. If the environment is poor, it will affect health. So we bring to bear the environment as part and parcel of improving health in the community. The third thing we do is we use data. Everything we do has to use data to be driven, evidence-based. There's no way you can change a system unless you are aware how it's performing or what impact, say, disease has on the community. For example, we know that in this country, maternal mortality and child mortality, both morbidity, sickness, illness, and death are highest among mothers and children. And that informs the focus, the priority focus for us to engage into improving healthcare. That's going to be our focus, and it's part of the focus of the government for the next few years. And we'll make sure that we use data to even track the improvement in the way we're addressing healthcare in this country. And we work towards the goal of sustainability. As I mentioned earlier on, we do not create new systems. We do not form new things. And we're here to support the government of Uganda reach its potential with the help from the American people. For that to bring to bear, we will work with existing structures. And we told our innovators out there, much as we have very good innovations, they may have parallel proposals, but a parallel proposal which is not linked to the existing national system does not additively add to the sustainability and achieve synergy as well as effectiveness and efficiency. So the USAID funded strengthening supply chain systems, it has one single goal. And that goal is to ensure that health commodities, essential medicines and health commodities of a quality nature are available to all Ugandans at all times, wherever they are. And also to ensure that whatever service we deliver is client-centered, it's person-centered. Because ultimately, when we are talking about healthcare, how does it come to bear? It comes to bear to the fact that you're reaching that patient, that pregnant mother who is sick. We have consortium partners, as Belinda has already mentioned. We have Advocates Coalition for Development and Environment and Uganda Healthcare Federation. Our activity has three main objectives. The first objective is the targeted improvement in the supply chain so that we can improve the way supply chain services are developed. The word is targeted. It means we are focusing where the gaps are. We're not looking at we are looking at the holistic system and removing the gaps to make it functional. Two, we are looking at good governance, where good governance looks at the policies and ensure that with good leadership to manage supply chain and essential services in this country. And finally, we're supporting the government of Uganda to increase local funding for health services in this country. Currently, funding for commodities in this country, 30% of the national budget, and 70% is covered by development partners. In the next 10 years, we're going to work with the government, with civil society, with the community to try and support the government, increase the use of our own resources to manage our own health services. Some of the key glaring existing challenges in supply chain are summarized in this slide. Currently, if you look at this slide, it shows the stock status of some key elements from a summary of health facilities in this country. We have ARVs, we have essential medicine and health supplies, we have laboratory commodities, we have reproductive, maternal, neonatal, and child health commodities, and TB. What it shows that when we did the snapshot, this is the current status of stock for essential medicines in the country for these drugs. Red represents a stock out status. If you take, for example, ARVs, 37% of the health facilities are stocked out on ARVs from the assessment we have. Only 20% are understocked, and only 13% of the health facilities have adequate stock, with 30% being overstocked. So what does that mean? It means we are living in a confused state of affairs. You're stocked out at one hand, you are understocked on the other hand, and you're overstocked on the other hand. And for those health facilities where there's stock out, it means patients are missing out on getting care, and yet you are overstocked in 30% of the health facilities. Why? The principal reason here is because there's a gap. There's no routine collection of data to inform supply chain. The data is missing. We're not collecting consumption data. Even our quantification and planning for procurement of commodities in this country is based on proxy data, issuing data from the health facilities, because we don't have access to consumption data, which would help us change this picture. So what it means that for all these commodities, we are adequately stocked in the country. However, in practical terms, some are missing medicines because they don't have, and because there's no data. There's no visibility of commodities which can help us realign properly plan and move commodities where they are required. So that's something that we need to be working on. There are gaps in governance, leadership, and accountability. Why do we have a situation where you have stockouts, you have overstock, you have expired commodities? It's because we, the leaders, the managers, are not doing our job very well. So we need to focus on governance and leadership to ensure those anomalies are corrected. Then we have fragmented supply chain systems at the moment, human resources, and more importantly, also limited budgets, as I mentioned earlier on. So in the next 5 years, with the support from the American people, structure so that it can reverse the current picture that we see. So how are we going to do that? Currently, there are entities which are in chain, warehouses are trying to set up electronic data collection systems, which will enable the health facilities to place their orders electronically through customer self-service. Principally responsible for private sector are doing that, and our role is to support this process that it happens. But the way it is right now, there's no linkage between the warehouses, the health facilities, and the pharmaceutical information portal, which is based at the Ministry of Health Department of Pharmacy, where the entire stock status and the planning for this country is occurring. We have different reporting systems. We have the health management information reporting system. We have the logistics information management information systems, and they're not aligned and linked together. So even as we have commodities in the system, that's why you have stock out, understock, overstock, because that system is not yet linked. The supervision by the DHL's office is not happening because they don't have access to the summary of the data, the reporting structures, and not even the governance from the National Drug Authority, from the good pharmaceutical practice and good distribution practice. It's supposed to monitor we are aiming to ensure that at the end of the next 5 years, we are focusing here to make sure that there is a linkage and a connection so that we achieve end-to-end visibility of commodities within the entire supply chain. The supply chain begins at the warehouses, management information systems, which send their consumption data to the Ministry of Health. So we have visible and actual stock status, which permits planning, permits the regulators, and at the same time, it also communicates with the community. Community tools, as we are trying to get drugs to the community, should be also to link into the system, as well as the governance from the district leadership. So this whole linkage of the supply chain and data visibility is the hallmark of our activity. We are looking at the priorities we have for this year. We are trying to support the government to make changes in the treatment of HIV infection. There are newer molecules, single molecules, easier to administer. That's going to be a priority this year. The second priority, we want people to receive drugs and be able to stay home and take their medicine over time, especially if they are well. And so we should be able to track the commodity in their communities, so they don't have to be burdened with out-of-pocket travel to the health facility. The third priority, as I mentioned earlier on, is end-to-end visibility, which will eliminate wastage, increase efficiency, and effectiveness of the supply chain. And we're trying to decentralize this by building tools, electronic tools and structures, so that, for example, free medicines like family planning commodities, like vaccines, can be safely given in the private sector because there's a mechanism to track and trace them without necessarily using a paper-based. That's part of what we are trying to focus on. And finally, the private sector is very critical in the care of health in this country. Over 70% of our population receives their health care from the private sector. And if they do see 70% of those who are participate in part of the national public health care system. One, to help with quality assurance, but two, to also reach that population which is treated within the private sector. And also, more importantly, they help with the procurement, with the manufacture, movement of drugs, and warehouses, because they invest in some of these critical things. And finally, the US government is interested in providing a mechanism where sub-entities at the sub-national level can receive direct funding and be able to use this money to help the people of Uganda. We are prepared capacity to manage resources directly from another government so they can use those judiciously for the purpose for which they were intended. I thank you so much. I will now invite the UNAID representative to give some remarks before the Director General opens up this meeting. Is he online? He's going to join us online. Dr. Edson Muhwezi. Thank you. I thank you, and I invite Dr. Edson Muhwezi.
Thank you so much, Dr. Eric Gada. I hope I am audible. Okay, the Director of Health Services, Dr. Henry Mwebesa, Mr. Noah Kafumbe, representing the USAID Mission Director, the Chief of Party USAID-SSCS activity, Dr. Eric Rugada, Minister of Health officials. I can recognize some commissioners and all partners present. We have Outbox and other, but I thank you. all for joining us today as shall be your select and incubate outstanding solutions, address health challenges in Uganda and in collaboration with the Ministry of Health and others. The nation is fund as we continue where we bring young people together, find solutions to explore new ways, while at the same time promoting social entrepreneurship. Important strides made by the government in improving commodities and services.
Dr. Muhwezi,
However,
I don't know if you can hear me.
Some
Dr. Muhwezi,
and innate human resource.
Dr. Muhwezi. Hello, Dr. Muhwezi. We can't hear you well. We can't hear you at all. What I propose is that we can pause you and we'll have you later. We will have the Director General give the opening remarks, and then as we sort out the technical glitch with you, and then we can have you on at a later. Did you hear us, Dr. Muhwezi? Before I invite the DG, the most critical element today is that we are launching the Innovation Lab for supply chain at the USAID supported in supply chain systems. And in this effort, we have collaborated with the UNFPA. We've worked together, and Outbox, the technical experts, they are supporting us to launch this system. It's going to be running annually, as Belinda said, and this is the first time it is happening. We're excited, at least to practicalize what we preach, which is innovation, and using the Ugandans and their thinking to bring to bear their support and that they can provide to improving our supply chain services. Director General, please, will you come and open the meeting?
Good morning, ladies and gentlemen. I think allow me to observe the protocol first. The Director USAID is represented by Noah and all other colleagues from USAID. The country representative, UNFPA, represented by Dr. Edson Muhwezi. Senior colleagues from Ministry of Health, in particular the Commission Pharmaceuticals, the Assistant Commissioner, Paul, and Paul NMS, I want to consider you as part of Ministry of Health. The Chief of Party, Eric, and your very committed and dedicated team, representatives of local governments, if there are any, the Executive Director, Grace, Uganda Healthcare Federation, all the innovators, any colleagues from the academia. I think I have recognized UNFPA, and if there are any other development partners. Invited guests, ladies and gentlemen, once again, good morning, ladies and gentlemen, and welcome to this very important meeting. To UNFPA, my sincere condolences upon the death of Cedric. I knew Cedric very well, but this crazy world, I even didn't know he had passed on. I've just learned it today. My deep condolences. I will request I keep on my mask. This mask has kept me alive. So I owe a lot of my life about this mask. So I don't want to remove it. Sometimes I'm in a meeting with colleagues in the office. We are writing, you are with them the whole day. And the next morning you hear they are positive. And some are admitted, some where you say, my God, am I safe? But you find yourself safe. So all that, I think, mask. Never remove my mask in many places. And that has happened to me 4 times, even my whole team in the office. And positive, but God kept me alive. So I still believe it is this mask. So once again, I want to welcome you to this very important meeting on behalf of the government of Uganda and the Ministry of Health in particular. And especially thank you for accepting to be part of this very important innovation, Uganda's first ever health supply chain innovation, which is being undertaken today. We are witnessing yet another product of our long-term partnership and mutual agreement and engagement with the government of the United States of America in our health sector, and as we say, the people of America. Allow me, more importantly, to extend gratitude to the people of the United States for this generosity, to the Ugandan people generally, and mainly for contributing to government's efforts to improving the health status of our people. I want to recognize here, and Noha, maybe you'll take our appreciation, that our relationship with USAID has been a very long one and a very strong one. This is one of the projects supported by USAID, but we've had a long relationship and support in the areas of reproductive health, in the areas of HIV, supply chain management. I think this is the 3rd project of its kind. Each of them 5 years, so that's 15 years of relationship and support to our supply chain. And we don't take that for granted. You all know the rights projects in the different regions of this country. You know the TB projects. You know the quality of care projects. And of recent, even into global health security, with respect to pandemics and epidemics. They have been there for us and supportive in strengthening systems to respond to those epidemics and pandemics. And more recently, even strengthening our health systems at the center, the human resource for health. They have been there for us. As we talk, we have now a lot of technical assistance in terms of human resource at the ministry. So we really appreciate that, and I really want to take time to highlight that, among others, because there might be some of our colleagues who are joining us may think this is the only support in the Ministry of Health from USAID. And I just wanted to show that USAID is our committed partner, and we have benefited a lot from that relationship. Specifically to this program, your inputs to the health sector, mainly through interventions in HIV, AIDS response, and health commodities supply chain strengthening, yield results at all levels. These notable results are reasons we see today as you continue strengthening through the USAID Uganda Strengthening Supply Chain Systems activity. So we are really happy and excited about this. And as the Chief of Party said, this innovation is to help solve health supply chain challenges, getting information from the public. So we are witnessing here, we'll be witnessing some innovations, and I'm told there are 9 out of which we'll select 3 and support those 3 over the coming years. And those will help to strengthen our systems in those areas that you have talked about. They could be anything in the area of monitoring supplies, could be anything in the area of manufacturing, local manufacturing. And as you know, these days, the president supports a local manufacturing. It could be anything in stock status, could be anything in monitor, as you emphasized lately, the issue of expired commodities. We are short of money, but sometimes you find us destroying essential medicine and supplies that have expired. So if we have a system that can help us stock status, in quantification, delivery, we appreciate and would like to partner and work very closely with you to strengthen those systems. Certainly, as you all know, this is a follow-on of efforts done by the previous projects, especially the MSH supply chain projects I talked about earlier. As I said, this is the 3rd. So, but the previous 2 did a lot of work, and I want to believe this is a continuation of that kind of support that we received earlier. And it is at this juncture that I really want to thank MSH for their very strong and supportive in this area, and they continue this kind of support. So as the Ministry of Health, we appreciate this support, and we strongly thank you. I want to comment on the issue you highlighted, and which is my emphasis today, is the issue of sustainability. We want sustainable innovations that will be built within our systems, within our health systems. And I was very excited when you mentioned that. And that meant to me that I don't have a lot of work to emphasize it, because it is part of your agenda. Because we want innovations that come and can strengthen our existing systems as part of health system strengthening at the center, in local governments, and even in regional referral hospitals. We don't want innovations or interventions that are introduced by a project or a program and then ends with MSH. It starts now, and when your project ends, the innovation or the intervention ends. In that case, you will not have done justice to the Ministry of Health, but you will also not have done justice to the Americans' money. But if it is something that remains and continues to be utilized, then there we are together and we are happy. The second point I wanted to emphasize is that even these innovations you produce, they should also see how they work or they link with already existing innovations or adapted within existing programs. And at this point, I'm excited that the 2 Pauls are here, Paul Umbaka and Paul Okwari, because we know there are many solutions in the Ministry of Health. So let's try to see how whatever new innovation, how does it with what is existing in the Ministry of Health, so that we don't just add to the already big cartel of too many innovations which are not talking to. So let's see how these innovations talk together, complement each other, and strengthen the system. Having said that, I want to emphasize that as a ministry, we drive towards the vision of 2040. And as you are aware, we have our National Pharmaceutical Services Strategic Plan 2021 to 2025. It's a 5-year plan, strategic plan. And under that plan, there's a priority area number 12, which emphasizes research, innovation, and development. And within that, there's even a recommendation to establish a pharmaceutical think tank for generation of innovations. So your intervention is aligned to that and is in line with the Ministry of Health strategic plan and actually in line with our health policy. We are further guided by the Lancet Commission on Essential Medicines Policies and the UN Secretary General High-Level Panel on Access to Medicines to create an environment for innovations. And as we do this, you should also refer to those very important documents. I'm happy to see that the Strengthening Supply Chain Systems activity will use the Innovation Lab approach, working in partnership and collaboration with the Department of Pharmaceuticals and Natural Medicines and other partners to generate and test novel ideas and innovations and use best practices from various sources. As you may all be aware, the government of Uganda, through the president, is committed to playing a critical role in sustaining and growing innovations. I think this has been very clear in the last 1 month, especially where you've been seeing some clashes here and there, but the president came out clear to strengthen and said, if Ugandans have innovations, actually one time he said, even if they are mistakes, but let them do it and we see. Because every innovation, we are not sure what will be the result. Every study, every intervention you do can be successful. It may not be successful at the end. Even the research, even as you try to, like if you see how many people are doing research on vaccines, there are over 200 the whole world. But it doesn't mean that we shall have 200 vaccines in the country. So some will be successful, some will fail along the way, some may progress to phase 2 or 3, some may even fail at the first phase. But the important thing is you need to start and move on and see how it goes. So that has been really the idea of the president, that if people have innovations, support them to develop those innovations, and maybe you may get out something very useful for this country. So as that's what I've been saying, an example is the efforts that have supported innovations aimed at addressing the challenges posed by the COVID-19. Collaborations with development partners, the private sector, that's why Grace is here, the academia, I don't know who is here representing universities, civil society, and end users are key in driving the health sector performance. For us, we consider that health is not the role of Ministry of Health alone. The role of our partners is very strong, the role of the academia, the role of civil society, because the academia helps us with research and development, guidance on development of policies, the civil society, the private sector. We all look at those as very strong partners in our efforts to deliver health services to our people. Therefore, we need to maximize these engagements and ensure that processes of engagement with stakeholders are strengthened. As I conclude, the Ministry of Health is committed to partnering with you and with all other innovators to realize the objective of providing universal health care to the vulnerable population of this country. This event offers a platform for these minds to showcase their great innovative ideas, and I really wish all of them success. Whoever takes the day, the 6 who may not make it should not give up. They should continue developing their innovations. I believe there will be other opportunities for them to go beyond that. I'm looking forward to seeing strong pitches from the innovators. I also wish them good luck, as I have already said. And I'm looking forward to seeing that these innovations are supported to scale. As I conclude, I want to thank MSH for funding this initiative and pledging or committing to continue to support it during the lifetime of the project. I want to thank them for the previous projects. I think I've already done that, implemented before this very present project. I want to thank your collaborators, in particular UNFPA, who are working very closely with you. And finally, I really want to thank USAID for this support for this very innovative work, and for all other previous support to this country. Ladies and gentlemen, once again, I want to thank you for God and my country. And at this juncture, I want to request Eric that you allow me to run away, because as I had told Belinda, even this one is borrowed time, because I wanted actually to be here physically because I was trying to avoid the situation we saw with the other one, because someone can let you down. So I said, let me run there, give my opening remarks, and then I ran here. But as you saw, as I was there, my minister was already calling me, because we are supposed to make a presentation. We are going to present to State House tomorrow about whether we will allow you to come out of lockdown or not. Thank you very much. Oh, yes, thank you very much. On that note, I have the pleasure to declare this meeting officially open. Thank you very much. Now, I don't want to leave you my COVID. At least I will not be responsible. Actually, it is actually very important. One time we were told, there are two people who have told us specifically who have got COVID from microphones. So it is important we sanitize before the next speaker.
Dr. Edison Muhwezi, we are trying to confirm whether you are able to talk now, whether you have a better internet connection. Just confirm.
Yes, but if I'm not able to make it, my colleague
Dr.
Moses Warakla is in the room. Hello, he should be
Yes,
able to deliver my speech
yes,
because I have sent it to him.
Dr. Muhwezi. Okay. So next on the program, we can have Dr. Moses Walakila.
Dr.
Who is
Moses.
going to represent Dr. Muhwezi Edison to deliver his speech. Dr. Moses Walakila, you're most welcome. Thank you.
Yeah, good morning, ladies and gentlemen. I've been requested by Dr. Edson Mohez, the Assistant Representative of UNFPA, to deliver his remarks. I do appreciate the Director General of Health Services that has just made his remarks and officially opened this meeting, the representative of the USAID mission, the commissioners of the Ministry of Health, the Chief of Party, Uganda Strengthening Supply Chain Activity, all partners present, members of the media, ladies and gentlemen. Thank you all for joining us today as we launch a supply chain focused innovation lab where UNFPA's App Accelerate shall be used as a vehicle to create awareness, source, identify, select, and incubate outstanding solutions to address the health supply chain challenges in Uganda in collaboration with the Ministry of Health, USAID, Research, and Outbox Uganda. For UNFPA, as we continue to innovate, it is important to facilitate a mechanism where we bring young people together to find solutions to explore new and engaging ways to improve the supply chain for reproductive health commodities while promoting social entrepreneurship. I applaud the important strides made by the Uganda government in improving the Uganda's essential health commodities and pharmaceutical services over the years. However, despite the notable achievements, there are still some existing systemic challenges throughout the health supply chain system, including stockouts, inadequate human resource capacity, among others, which impact the access and availability of quality health commodities. Specifically under this collaboration, UNFPA, MSH, and Outbox will leverage each other's strengths to map and engage various stakeholders in public and private sector to improve the health supply chain in Uganda and advance the Uganda's national medicine policy agenda in increasing the availability, accessibility, affordability of essential health commodities and pharmaceutical services. The Innovation Lab shall be launched with a call for innovations, but will later establish learning forum, learning exchange platforms, develop knowledge products, research, and publications. By tapping into the network of young entrepreneurs and providing them with seed funding, mentorship, and technical support, the Supply Chain Innovation Lab has the opportunity to develop market-ready, scalable, and sustainable solutions to strengthen the reproductive health supply chain systems. Therefore, it is important to keep adapting and finding relevant modalities, such as this initiative, to respond especially to the devastating effects of the pandemic, which have disrupted the supply chain for reproductive health commodities, resulting in delays in ensuring the last mile delivery of the essential health commodities to the health facilities and the community distribution points. Colleagues, thank you very much. So those are remarks from the Assistant Representative UNFPA.
Good morning, everyone. You're welcome to the pitch day. and thank you so much to all the speakers so far we've had. We are going to take the next 10 minutes to have breakfast, and then we should resume in the next after 10 minutes. So let's try to maintain social distancing as we go for break, maybe 3 at a time. Let's try to keep it within 10 times when 3 people. When we are done, we shall have Moses come and introduce the judges, and then later on, we'll introduce the teams that are pitching, and each team will have a go at it. So let's begin with the judges. Let's go for break, and then the participants will follow next.
The movement of medicines and supplies from the manufacturer through warehouses and health facilities to patients at the right time and in the right quantity is faced with challenges of insufficient information on consumption and the quantities of medicine and supplies available at health facilities. This lack of information has affected the Ministry of Health and Partners' ability to accurately quantify how much life-saving medicines are needed. This leads to frequent stockouts, wastage, and expiries. These challenges are largely attributed to paper-based manual process and fragmented electronic supply chain systems.
In the past, we have previously depended on manual reconciliations.
Our management system here, stock management system, comprises using stock cards, stock books to input what we received, but then also to input what we've been able to issue out to user units.
To solve these challenges, the Ministry of Health, in partnership with USAID, Uganda's Strengthening Supply Chain Systems Activity and partners, are embarking on digitizing and integrating supply chain to improve end-to-end data visibility.
So the current digitalization of the medical records is good for us because we're able to capture records in real time. This has greatly improved in reduction on stockouts of key items that we use in the hospital.
Commodities are coming from national medical stores. We input them into the system. When we input them into the system, the user units order for them, track our consumptions, to track expiry, to track use, to track accountability. Now, that means Ministry of Health can easily to our information to RX solution to be able to better plan.
Most of the facilities are using RX solution. However, new systems have come on board. We have the IICS, or Integrated Health Management Information System. Then we have the ERP, which is being tested through client service self portal.
Integration of systems has come out strongly as one of the things that we need to do to encourage information use for strategic decision making and guiding policy formulation.
The goal is to link all health facilities to the central warehouse. Public health facilities will be connected to the new online NMS plus client self-service portal, CSSP, to order medicines and supplies from national medical stores.
CSSP is giving us a platform where we're going to be able to submit all these reports at once within the same portal. That means we can easily follow up on which orders have not yet been submitted. We can easily know who actually has worked on which particular order. We can, most importantly, have the director more engaged into our ordering.
Private not-for-profit facilities are connected to the Joint Medical Stores platform and can order supplies through the DHIS2 ordering app for all program commodities.
We look forward to ensuring that all these isolated systems are communicating, and likewise at the warehouse, they will be able to monitor their pipeline. And also that we have given access to the district health officers and the district directors. So at any one time, they can log onto the system and see how they are faring as far as order placing is concerned. And then the health facility will also benefit. Their capacities will be upgraded to use. Some of them will get computers, some of them will get internet. And
with this real-time information sharing between the health centers, medical stores, and government, Access to a consistent supply of medicines and health supplies is guaranteed to improve the quality of care. In Uganda, the movement of medicines and supplies from the manufacturers through warehouses and health facilities to patients at the right time and in the right quantity is faced with challenges of insufficient information on consumption and the quantities of medicine and supplies available at health facilities. This lack of information has affected the Ministry of Health and partners' ability to accurately quantify how much life-saving medicines are needed. This leads to frequent stockouts, wastage, and expiries. These challenges are largely attributed to paper-based manual processes and electronic systems.
In the past, we have previously depended on manual reconciliations.
Our management system here, stock management system, comprises using stock cards, stock books to input what we received, but then also to input what we've been able to issue out to user units.
To solve these challenges, the Ministry of Health, in partnership with USAID, Uganda's Strengthening Supply Chain Systems Activity and partners, are embarking on digitizing and integrating the entire supply chain to improve end-to-end data visibility.
So the current digitalization of the medical records is good for us because we're able to capture cost every time. And this has greatly improved on stocks of key items that we use in the hospital.
Commodities are coming from national medical stores. We input them into the system. When we input them into the system, the user to track use, to track accountability. Now that means Ministry of Health can easily tap into our information through our RX solution to be able to better plan.
Most of the facilities are using RX solution. However, new systems have come on board. We have the IICS, or Integrated Health Management Information System. Then we have the ERP, which is being tested through service self portal.
Integration of systems has come out strongly as one of the things that we need to do to encourage information use for strategic decision making and guiding policy formulation.
The goal is to link all health facilities to the central warehouse. Public health facilities will be connected to the new online NMS plus client self-service portal, CSSP, to order medicines and supplies from national medical stores.
CSSP is giving us a platform where we're going to be able to submit all these reports at once within the same portal. That means we can easily follow up on which orders have not yet been submitted. We can easily know who actually has worked on which particular order. We can, most importantly, have the director more engaged into our ordering.
Private not-for-profit facilities are connected to the Joint Medical Stores platform and can order supplies through the DHIS2 ordering app for all program commodities.
We look forward to ensuring that all these isolated systems are communicating, and likewise at the warehouse, they will be able to monitor their pipeline. And also that we have given access to the district health officers and the district directors. So at any one time, they can log onto the system and see how they are faring as far as order placing is concerned. And then the health facility will also benefit. Their capacities will be upgraded to use. Some of them will get computers, some of them will get internet. And
with this real-time information sharing between the health centers, medical stores, and government, access to a consistent supply of medicines and health supplies is guaranteed to improve the quality of care. In Uganda, the movement of medicines and supplies from the manufacturers through warehouses and health facilities to patients at the right time and in the right quantity is faced with challenges of insufficient information on consumption and the quantities of medicine and supplies available at health facilities. This lack of information has affected the Ministry of Health and partners' ability to accurately quantify how much life-saving medicines are needed. This leads to frequent stockouts, wastage, and expiries. These challenges are
Hello,
likely
everyone.
attributed to
We are
being
resuming in the next 90 seconds. So if you're getting your cup of tea, make it as quick as possible. So this implies we are going to have a working breakfast. Judges, wherever you are, please return and take your seats. We want to start right away. Ladies and gentlemen, we are resuming. Allow me invite Mr. Moses Mukundane, the Strategy and Program Innovation Director at USAID-SSCS activity.
Thank you very much, Bob. Good morning, ladies and gentlemen, present physically and those online. All protocol observed. My name is Moses Mukundane, the Strategy and Program Innovation Director of the USAID Uganda Strengthening Supply Chain Systems activity. Seconded to the activity by one of the consortium partner organizations, the Advocates Coalition for Development and Environment, ACCORD. My task this morning is very simple. Just to take this opportune moment, of course, with enormous pleasure and honor, to introduce to us a panel of distinguished judges who will make the final assessment and evaluation of the innovations and eventually select the top best 3 winning teams. And without necessarily following any particular order, ladies and gentlemen, here are our judges. One is Mrs. Neville Okuna Oteba. And just a little about her. She's a pharmacist by profession with several postgraduate trainings in pharmaceuticals and project management. She has served in the Ministry of Health for now 30 years with that dedication in different capacities, but largely in the pharmaceutical subsector. She's very passionate about the growth, both qualitatively and quantitatively, of the national pharmaceutical subsector of Uganda. She's currently the Commissioner Health Services in charge of the pharmaceuticals and natural medicines in Uganda's Ministry of Health. Ladies and gentlemen, a round of applause for Mrs. Neville Okuna Oteba. Next on the list is Dr. Eric Stephen Lugada, a medical doctor by profession, with a PhD in medical epidemiology. He is very passionate about building resilient health systems with a bias in health commodities supply chain. He has a vast international exposure in implementing in-country and multi-country health programs, largely in HIV, AIDS, and also generally in health systems strengthening interventions, largely funded by PEPFAR through USAID, CDC, and Department of Defense, but also implementing other projects funded by DFID, UNDP, and UNFPA, among others. He has worked, because he began his career here in Uganda, moved to Kenya, Tanzania, Nigeria, Sudan, among other countries in sub-Saharan Africa. And as the saying goes, that what goes around comes around. He's back in the country and is currently the chief of party for the USAID Uganda Strengthening Supply Chain Systems activity. Ladies and gentlemen, a round of applause for Dr. Eric Lugada. Next on the list, ladies and gentlemen, is Mrs. Grace Sally Chwanuka, who is the Executive Director of Uganda Healthcare Federation, UHF, an association of association, a membership umbrella body of over 65 organizations that are involved and engaged in the Uganda private health sector. She's very passionate about championing the interests of the private sector actors in this country. Ladies and gentlemen, a round of applause for Mrs. Grace Sally Chwanuka. Next, ladies and gentlemen, is Dr. Noah Kafumbe, who is a senior supply chain systems advisor at the USAID Uganda mission. And most important, he is the agreement officer's representative, punctuated as AOR in the USAID language, for the USAID Uganda Strengthening Supply Chain Systems activity. He advises government of Uganda on health supply chain policy framework. Ladies and gentlemen, a round of applause for Dr. Noah Kafumbe. Next on the list, ladies and gentlemen, is Mr. Dennis Chibira, who is the Executive Director at the Coalition for Health Promotion and Social Development, HEPS Uganda, and is also a Regional Coordinator for the Health Systems Advocacy Partnership at Health Action International. He's a pharmacist by profession and very passionate about the functional healthcare systems in this country with a bias in community health systems. Ladies and gentlemen, a round of applause for Mr. Dennis Chibira. Ladies and gentlemen, I'm also privileged to introduce to us Dr. Moses Walakila, a medical doctor by profession and a public health specialist with over 17 years of experience in integrated health, programming, and implementing largely most of the PEPFAR-funded public health programs over the same period. He is currently the program specialist in charge of family planning at the United Nations Population Fund, UNFPA, Uganda County Office. Ladies and gentlemen, a round of applause for Dr. Moses Walakila. Next, ladies and gentlemen, is Mr. Paul Mbaka, who is the head of Division of Health Information in the Ministry of Health, and he is very passionate about digital transformation of health sector of Uganda. Ladies and gentlemen, a round of applause to Mr. Paul Mbaka. Next, ladies and gentlemen, is Mr. Martin Oloa Oteba, a pharmacist by profession, training, and practice, with various postgraduate trainings in pharmaceutical management, international public health, and business administration. He served in the Ministry of Health for over 30 years in different capacities to the level of the Assistant Commissioner Health Services in charge of the pharmaceuticals at the time he left the ministry. He is presently the Deputy Chief of Party and Program Technical Lead of the USAID Uganda Strengthening Supply Chain Systems activity and is joining online. Ladies and gentlemen, a round of applause for Mr. Martin Olowa Oteba. And lastly but not least, ladies and gentlemen, is Mr. Dennis Okidi. He's a pharmacist by profession with over 13 years of experience in that sector and is very much passionate about digitalizing of the health sector, but also improving transparency and accountability in the health commodities supply chain. He is currently the Director Supply Chain at the USAID Uganda Strengthening Supply Chain Systems activity. Ladies and gentlemen, a round of applause for Mr. Dennis Okidi. Ladies and gentlemen, that is a panel of our distinguished judges today who are yet to determine the fate of the day, and especially for our innovators today. I wish you good luck. Thank you very much for listening.
Thank you so much, Moses, for introducing our judges. Can we give them a round of applause? So in the next few minutes, we'll be starting, and I'll be sharing with you the lineup of who is going first. Allow me to introduce myself. My name is Bob Ogwang, and I work at Outbox. We're a supportive partner on this journey. Outbox was founded in 2012. We're an innovation and entrepreneurship support organization. And through our Up Accelerate initiative, for the last 5 years, we've been supporting social entrepreneurs to create innovative solutions that are helping the country reduce cases of GBV and also ensure there's uptake of SRA-HR information across the country. It's against this background that we're deemed fit as a partner to support on this initiative, and we support various organizations and entrepreneurs bring their vision to life. We are really excited to walk this journey with you. And over the next few minutes, I'll be introducing to you who is pitching and who is not pitching. So for starters, as you can see, we have 9 teams. From the over 130 teams that we had, through the judging criteria and a select panel of judges, we're able to trim down the number. And I must tell you, the selection wasn't easy. The teams had amazing ideas, but it had to come down to who is who had what we're looking for according to the judging rubric or the selection criterion. And we came down to these 9 teams that will be pitching today. So we had 10, and through the speed dating activity, 2 of the teams realized that they were offering a similar solution, and they decided to merge and form 1 team. So that's why we shall be having 9 teams pitching today. So what are the rules? Each team will have 7 minutes to pitch. I have a bell there. I'll sound that bell at the 5-minute mark to alert you that you have 2 minutes to go. At the end of the 7-minute mark, I'll sound the bell twice to signal you that your time is up, and the remaining 7 minutes will be used by the judges to seek clarity on on anything that might have not come out right. Also, they'll use the 7 minutes to answer 2 questions from the online community. So in case a team is presenting and you have a question, feel free to post the question on our YouTube channel. Our team is working around the clock to receive the questions, and the teams will respond to them immediately as soon as the 7 minutes elapse. So, who is going first? Oh, I've gone so far. Oh, we'll have Drag Dash speech first, and they will closely be followed by Chaguzi and then Signolitic. So those will be the first three teams. And when you come here, you have a clicker to use. And like I'd mentioned, your time is strictly 7 minutes. So without wasting time, allow me invite the first team to come and make their presentation. Drag Dash.
Network. Sorry. Need to manage. Good morning. My name is Samson Kapei. I'm waiting for my presentation to go up. All right, let me just test the clicker. Okay, cool, we're good to go. Good morning, my name is Samson Kapei, and I'm here to tell you about Drag Dash. In the last financial year, the health sector budget was only 5.1% of the total country budget, right? And so if we have a population that we need to serve that is as big as we have in the country, we need to make sure that we use the little resources efficiently and effectively. And I'm excited to tell you about how we are going to do that, right? And I'll start with a story. If there's a time when the news was always filled with, stockouts in the facilities and all the issues around it. And so we set out to understand why that was happening. And we did a pilot in Bukedia, and we found that one of the problems that was leading into the stockouts was the district health officers did not have information on their hands to respond quickly to the needs and issues around the people that they're supposed to serve. And so we built an offline fast web and mobile solution to enable these DHOs to have information on their hands so that they can make timely decisions based on evidence and react faster when issues arise in the facilities. That mobile solution sits at the facilities. They collect information on stock. It's transmitted to the dashboard, and in real time, the DHO has information on his hands about what's going on in the facilities. When we did that, the DHOs were now able to respond in terms of redistributions because they knew which facilities have low stock, which facilities have high stock, and how can they move that stock around between the facilities to make sure that they respond to the emergencies. And part of our dream is to build interconnectivity between the districts and not just within the district, right? My presentation, please. Right. Cool. So when we built that solution, we piloted it in 56 health facilities and in 2 hospitals in 5 districts. Because now the DHOs and the health facility managers have information in their hands, they are able to make quick calls and redistribute. We've seen 148 redistributions during the pilot phase, and we have seen that 48% of these facilities have improved compliance to reporting because the system is able to remind them, report on this, but also the DHO has information and it can make calls quickly and say, I haven't seen what's happening at your facility in 2-3 weeks. What's going on, right? We have learned amazing things during this pilot. One of these being that we need to build tools around the existing paper-based solutions. And so we built DrugDash based off HMIS 1015 and all those other forms that work at the facilities. And then the other important learning was that integration is key. There are so many systems that these health workers have to deal with. And so we need to make it easier for them to do their job, right? And also we found that these people are knowledgeable and that equipped with the right tools, they're able to serve their communities better. And so we see new areas and opportunities. One of these, we've divided them into two in terms of scaling. Can we go to other districts, right? In our pilots, we've also been working with family health commodities. Can we scale to other essential medicines and health supplies, right? In terms of integrations, we see opportunities in terms of dispensing. I think you've heard in the remarks that there's no way people can tell what's happening once the drugs reach the facility. So can we build integrations and get this data from dispensing and put it at the hands of the people who need it the most to make the right decisions? Can we help these facilities report easier, right? Instead of filling out forms all the time, how can we build tools that if not replace all that work for them, it eases it. I'll give you an example. If NMS does distributions and then they come with papers for the facilities to verify what they have received. Imagine a world where that data is transmitted to DrugDash. When the truck reaches at the facility, the data is already loaded and they just need to check it, click a checkbox and say, okay, we've received this, or type back any remarks if something is not correct. And that information is immediately transmitted back to NMS for them to react quicker, even before the truck finishes all the rounds to take back all the data. And then we see opportunities in community outreach services. There are private facilities and dispensing points that are giving out ARTs, and we see that the ARTs and TB drugs, and so we see that there's a world where we can put them as part of this network, which I showed you in one of the presentation, to make sure that they benefit from this network, which responds to these issues. My presentation. Could you just go to the next slide, please? Okay. Could you just go to the next slide, please? All right. So if we are able to get this opportunity to work with all the people around here and receive this funding, because there are so many systems that we need to integrate with, we are hoping by December, we've done studies and learned how all these systems operate and how we can integrate. And if by March we are able to deploy to these facilities that we have talked about, then that would be good. And then in June, we are able to, start monitoring and evaluation on how everything is working. We have an able team. It's split into finance and admin, headed by Rahma. We have a business analysis team, which basically understands requirements and puts them simply into understandable things that the technology team, headed by me, can build. The business analysis team is headed by Joan. We also have a training and user support team headed by Solomon. So, ladies and gentlemen, in conclusion, we have all these limited resources, but we also have the tools and technologies and the capabilities to build efficiencies in the things that we do. And that starts with collecting the right data, transmitting it efficiently, and putting it in the hands of the people who are supposed to make the decisions. I call upon you to join us to see the change that we want to see in the country. Thank you.
So judges, you have microphones in front of you. You can take it away. You have up to 7 minutes to seek clarity.
Yes.
I would like to thank the Drug Dash team for a very good presentation. Could you please highlight on the issue of affordability? What is the financial implication of implementing this?
Right. I'm glad that you asked that question, and I saved it for last. So to roll out to 10, so because of the way the structure is, you have a district that has multiple facilities, right? In a scenario where we have a district that has 10 facilities, the cost of rolling out the mobile component is about $1,000 for the 10 facilities, and then a monthly maintenance fee of about $200 to load data on each of the tablets so that they can continue to submit data. We load that data remotely and we monitor usage and respond depending on how that works.
Thank you. Thank you, Samson and the Drug Dash team. I think the question that I have rotates around the value proposition in terms of if you are the successful team, how will you position the funds that you will be able to get from this competition? You provide a number of areas, integration, scale up, but you know the funds are limited. So what is it that you want to get out of this competition? And also, how are you going to position it to either do the scale up or the integration aspects? It didn't come out clearly from your presentation, but otherwise the problem is clear, innovation is exciting, but where is it that you want to position as a niche in this to extend or integrate your system a bit more, given the space that you're working in? That didn't come out clearly. Thank you.
Thank you very much for the question. So the reason why we split this into scaling and integrations is because we see, and we already have a tool that works and that has been tested in the 56 health facilities. And so loading another list of commodities for them to report on is, 5 minutes work. So scaling in terms of, commodities is easier. And then in terms of, we have learned some things around, how do you train effectively? We have built people who are called Drug Dash champions in all the districts that we help with that can help us roll out. And so we see a world where we can do a bit of both, a bit of scaling and continuing to work the way we've been operating in other districts to give that value to them. But we also want to go beyond what we've been doing and start to add value to other systems in terms of the integrations.
Hi, just a clarification. You said that 48% of the pilot facilities saw an improvement. What were the challenges for the 52% that didn't?
Right. One, they had all these papers that they would fill out on to report according to the guidelines, but there was the distance between, for example, the district health office, which does the monitoring, is about 12 kilometers in Bukedia district, which is one of our pilot districts. And so by the time someone moves from the district health office to come and see what is in the scorecards at the facility, it's probably because they're responding to an emergency. And so when we give them a tool that and they know that, if I don't report, the Drug Dash team or someone at the district health office is going to call me and ask what's going on, they were able to respond easier. I think the other interesting part about them reporting is for most of the systems, they just fill in data and they just fill in data and they don't see what's coming out, right? In the mobile component that we built, as soon as you fill in data, you're able to see, I have this in stock. I have this which is out of stock. I have this which is about to expire, and all those things. So they were able, because they see all that information in real time and they can respond quickly. They saw the value in that, and so they said, let's keep reporting, because it even helps us know what's going on at our facilities without having to dig through all the paper records and find what's going on. The other interesting bit was the calculations we do around months of stock and all those other calculations that are incorporated. They don't do that anymore. All they do is fill out the stock and the system calculates those, and they are happy to not have to, do those calculations and feed them into other systems.
Yeah, maybe the question I have, generally, how was the acceptability and what was the involvement of the key supply chain stakeholders, especially at the decentralized level?
Right. Sorry, I have to keep going through the slides. So in terms of acceptability, there's two sides to it. In terms of the health workers, we spent a lot of time understanding how they operate and what their key pain points were, and we designed for that in the system. So we made it easy to use so that they can easily adopt it. In terms of key partners, they were excited to see this data in real time. They were excited to know what's going on, and they were excited that the solution proposed some of the pain points that they were dealing with at the facilities, and they were able to see some value. Once they were able to see value in what the system was doing, it became easier for them to accept it, to a point where in their meetings, we kept getting calls, we've heard Bukedia is doing this. Can you come and roll this out to Kitgum, right? Because they've reported that it is helping their work.
Thank you, Dash team. I think wonderful presentation. Looks like this is already existing. You're already on the ground with this application and planning to scale up. How do you plan to handle, or from your experience, offline capability? This is a web-based application. We know that connectivity, power issues do happen in most of the remote areas. So does this application have an offline capability that still work can go on? By the time the system is back online, you've not lost your data. Could you expand on that, please?
Right. So the primary source of data for DrugDash is the mobile. Component, which is installed on a tablet and placed on at the facilities. The mobile component is offline first. So even without connectivity, it will allow them to put in their data. Issues around connectivity and electricity. The reason why we chose a tablet version for the facilities is because when they don't have power at the facilities, they can easily, grab this tablet and, take it somewhere for charging, and then they can continue. And once they do that, there's a high likelihood that the place where they've gone to charge, there's also internet, and so the application can synchronize. And then the other interesting part is, their tablets, they are small solar panels, which cost about $30 that you can give, that we bundle with each tablet, so that they never run out of power in the tablets.
Thank you, DrugDash, for that presentation. I have one quick question. I think use of mobile data on a national database is a temporary fix to a challenge, an existing challenge. And right now, we're working with the warehouses to create a customer self-service portal, which will link the health facilities to the warehouses. And then from the warehouses, we're expecting to strengthen the collection of consumption data, which will be sent to the pharmaceutical information portal. So the symptom of redistributing drugs was relevant and still relevant right now. But as we move to build a system, the relevance of, in fact, redistribution is not a good practice and shouldn't happen. But now we're going to move towards a status. Once all these health facilities are linked to the warehouses and linked to the ministry, there will probably be no need for redistribution. But there's still need for an application. How do you see yourself adapting and converting this application in the times that are coming forward instead of moving backward? Because we need to adapt and address the existing need. Because right now we're going to move to a stage where we need to use existing national health supply chain reporting electronic logistic management information systems. And it's good to have the summaries, to have those dashboards, but the dashboards probably have a different need and support. How do you adapt and move towards the new the system that we are trying to put together? Because in its current state, it's addressing the old. The old is not yet out, but we need to move towards the new so that we don't get stuck in the old solution we're trying to solve.
Yes, thank you. So part of the integrations that we want to do are aimed at predicting a world where we've moved away from where stockouts are, right? So the integrations with HMIS and dispensing are based around encouraging provision of and availability of data, right? In terms of what's happening in the population, what diseases are occurring, what is the prevalence rate, and how can we build around that. So the new integrations that we are doing are not just on stock, but also reporting, so that we can make it easier for the health facility workers to focus on providing health care, as opposed to also working with the tools. So we want to make it easier for them to do their work and also report back, and the integrations are aimed at automating that process.
Right. Thank you so much, Samson. We also took one question from the online community. They say, thank you, Samson, for innovating the drug dash board. What baseline, since you are now at 48%, what were the key strides that made you reach 48%?
So it was difficult to do any redistributions in the beginning because, again, there was no way to tell what is where or what is not where, right? And they didn't even see how they could do this. Because there's some logistics that's supposed to be involved. The DHO calls the facility, do you have this? No. Then they call another facility, do you have this? No. And then it's a lot of work for them to get to a point where they find stock that needs to be moved around. And so when we were able to provide this information, then we saw, that's how we saw the rise in terms of moving from almost 0 to 48%. Bob, the second part of the question was?
The second part was, what were the key strides that made you reach the 48%?
So I talked about this earlier. The key strides were once people were able to see the value that we are putting in their hands by reporting in a timely manner and reporting accurate data, then it was very easy for them to pick up on and say, okay, so if I do this, this is how it benefits me, and so I'll keep doing it. So that was key for us in terms of stride.
Just one question.
Thank you.
Hello? Yes, I just wanted to know, and I think I might be refining a question that was asked earlier, related to mainstreaming. I realized that you have a team that is running the app, but when you look at this app in the future, are you seeing it working as a module within an existing platform, or as a platform of its own? And then how is the support team structured? Because I noticed you have not tried to mainstream it, with the exception of the people who are providing the data and those that are interpreting it, but the entire support structure seems to be like a standalone. So how do you see that, even with issues around scaling and so on?
Very good question. So one of the reasons why we joined this challenge is to get access to other key partners in the supply chain, so that we integrate with them and ease some of the pains that they have in what they are doing, right? So we don't see Drug Dash as a standalone system, and that's why one of our focuses in part of scaling up is understanding other systems and how we can build APIs to integrate these systems. So to answer you, Drug Dash would be a module which is part of other systems and not a standalone.
Thank you so much. I think our questions are done. Please take your seat. Let's have Ben from Chaguzi.
Click I'll have to let me try. Okay. Well, this is the trouble. Where is the receiver? I'll probably just request. I'll just say next slide, okay? Okay, maybe you fix it. Oops. Just a second. Ready? Good morning. Chaguzi and the White Ribbon Alliance present Chaguzi Mobile Care, enabling public to find medical services and products. The problem and the opportunity. We start our journey with Agnes. Agnes's child has measles. To access medical care, she has to commute 5 kilometers or so to the nearest health center, even though previous visits have been disappointing, occasioned by long waiting hours, medication stockouts, and limited or no information on alternatives. Where we see the opportunity, the digital revolution, sorry, is this me or you? The digital revolution allows us to help Agnes with the options and intelligence about her concerns by, one, creating a real-time database into which providers feed information about their services, stroke products, and availability. Two, providing the information through a mobile app that Agnes can access through a smartphone from her neighborhood support. And lastly, taking advantage of the growing smartphone ownership and acquisition in Africa and Uganda, most particularly. We put the statistics at the bottom. I hope you'll be able to see that on the acquisition. Our solution, in addition to solving Agnes's concerns, the Chaguzi app can also allow Agnes store her child's medication records, blood group, lab results through imaging, empower providers as they can identify where to refer Agnes for specific services and products. Thirdly, empower health facilities manage and identify where to purchase commodities. We started with the private sector, and we can adapt this to the public sector. Next slide, please. It can be accessed, the app can be accessed through Google Play Store, free of charge, through various categories. If you're a doctor, if you're a medical health provider, or if you're a general user like the millions of Agneses. Next slide. So the app would look like this, with a drop-down menu that shows what we have on the app, includes news, drug directory, pharmacies near you, doctors directory, insurance, etc., etc. We've presented for you the search function, which by icon shows pharmacies near where Agnes would probably want to get her medication in her region. And also the search, the further search that you can access would get her measles antibiotics for her child. Our mission is to empower communities and providers decide on the best healthcare services and products near them. Chaguzi's business model. What we've done in the first column, the second column, type is the kind of user. The second column is the kind of charge. The charge would be getting revenue from to run the business. So we have the various categories, as I mentioned, that can be onboarded onto the app. And in the last column, we're showing what it would be after 12 months of operation. 9 months would be free for all users to onboard them. So we're showing you through a market base of about 520,000 population in Ginger, where we'd like to start the pilot, ably partnered by White Ribbon Alliance. Excuse me. Our uniqueness. We would pride ourselves in saying that we are a bottom-up approach. We're speaking to the Agneses who pay as much as 20 cents, all of 20 cents a month in the last 3 months, which is affordable. The ease is a simple click, ease of information. Cost maintenance is low. We're a small operator. Information is easy to understand, and scalability, as we mentioned in the slide, we're able to scale up through increasing our server size and the dashboard. What we also do is that we have information of a marketplace and an inventory market speed. Our channels would include the various actors, both up from direct communication and, sorry, next slide, please. All these, government, private sector, etc., etc. Our traction has been ably accepted by national drug authorities and Uganda Medical and Dental Practitioners Council. What we're asking for is for $38,450 with various breakdown. That's our traction. Our roadmap, we see at the end of this, we started off with 500,000 users, 30 health partners, and by the end of it, we would have garnered 2,000 general users, 84 health partners, and would also want to participate in creating a national incubator to address the segment needs. Thank you for your time. Ready to take questions. Okay, if I had a minute to spare, at least show the folks who I worked with. That's me on the top. Arthur's the IT specialist. Dr. Rose is the executive director of White Ribbon Alliance that's able to put us together with a group of advocacy partners. Thank you very much. Let's see Agnes Katende, and I'll take the question. Thank you.
All right, so quickly, we'll receive all the questions and respond at once. Let's keep them to at least one for interest of time.
Next slide.
Thank you, Chiguzi Mobile Care, and a wonderful presentation and the idea. I have just, my question is twofold for clarification. Yes. Hypothetically, I think Agnes is urban-based, right? And the idea is based on the premise or assumption on the growing technology of smartphone. How scalable is that beyond the smartphone technology, beyond Moroto, Amuru, Nakapirit, right, for those users? And then two, maybe you help us unpack on the app maintenance. I know there's a fee or cost to sustaining this application. So if you could help expound on that, thank you.
Thank you very much. Basically, I would categorize Agnes, well, you said she'd be, in your view, she's probably urban because of the dedication of probably around smartphones. However, peri-urban and rural, our thinking was around the fact that at any level, that's why we mentioned that perhaps a health officer, there'll be one phone that could be accessed as a basic point. The growth of technology will happen. In addition, we are seeking partnerships with the likes of, we've heard a lot of innovations in the USSD formats, which don't require and require mobile technology. We've also seeking partnerships with the groups like National Medical Stores, who are big, who've invested heavily, and they do have that kind of format in place that reaches the last mile person. So once we get that, and it's part of the plan, we'll be able to serve the various levels. I hope I've answered your question. As regards to maintenance, well, we have a business model that would allow us continue doing our work side by side. However, with the various partnerships, we'll try and piggyback on some of the things they're doing so we don't repeat them. Okay? Next question, please.
A quick one. I know that healthcare, the public healthcare is free of charge. A patient in Luka or in Kabiramaido or Amudat can't even afford the basic necessities. How will they be able to afford to pay for the subscription of this app? I'm just thinking, looking at affordability, how do you think that could happen?
Okay, basically, our model is trying to fuse public and private as one. Hopefully, we can onboard, even now we have the capability of onboarding any private facility like we do any public facility like we do with private, up onto the app. They provide the inventory, or they sign up. Now, they can cater for the less. Now, those who would prefer, we're not being elitist, we're saying we're going to try and run a 9-month free pilot from when we start. Thereafter, would the Agneses, we can make that conclusion, would the Agneses be able to afford that amount of money? But the provision would be through the public onboarded facilities with all the benefits they're able to get at a public level, or not for profit as well. I hope I've answered your question.
Hello? I think the guidance was that you take all our questions and then you answer at the end.
Oh,
Yeah.
sorry.
So
Yeah.
maybe I can ask mine now. Yeah, so I realize that you have a flat monthly fee, but we have Ugandans who can spend a whole year without needing to go to hospital. Why isn't it service-based? When I access the service, I pay.
Sorry, I didn't get your question.
So according to your structure, people pay a monthly fee to access the service. But we have Ugandans who can go a whole year without needing to seek medical care. So I was wondering, have you considered making it
access based. Like on the day when I access the service, I probably pay for that access. Thank you.
Thank you for that great observation. So we'll definitely be able and make a provision as you go, as a pay-as-you-go service on the need. That provision is possible and the capability is there. When the people would like to start paying, but we have a built-in subsidy for whatever. Even now, to date, dealing just with the private sector, we give them a freemium period of up to 6-7 months to accept or not accept, but they try all the facilities and see what is required.
Yeah,
Thank you.
maybe Agnes may be one of the ordinary and poor Ugandans that may not be able to pay for the service or for any medical supplies at any of the facilities or pharmacies that are highlighted. Broadly, we have three categories of commodities. We have the free, like in public health facilities. We have the socially marketed. We also have the commercial commodities as well. So if you get into the app, will Agnes be able to see which type of commodities or which type of services are free? Because she may not be able to go to any facility. A facility might have them, but she may have challenges to pay for the service. So she will be able to, will she be able to see the payments, the related payments to the services?
Thank you very much. Most definitely. As long as the system provides, and thank you for helping me speak more of what we call a marketplace for the health providers, where they're able to onboard their pricing amongst themselves and share. However, at the level of the individual, say Kalangala or Kayunga Hospital signs up with the Chaguzi app, or the ones in Ginger for this matter, they would put all the stocks inventory with their pricing or no pricing. At the same time, Agnes is able to be getting alerts from the system generated.
Ben, our time is up, so
Okay.
use the next 10 seconds to respond to that last question.
Yes, most definitely. It can be done, depending on the groups, whether private, not-for-profit, private, or public. Thank you very much. Appreciate.
Thank you so much, Ben. Let's give him a round of applause. Let's have the team from Signolitic prepare to come up.
Greetings, everybody. Let's give the IT team a moment to get me access to the presentation. Okay, thank you. Okay. Yep. Okay, any moment now. Okay, thank you very much. Let's get started. Okay, my name is Elvis. I'm a co-founder at Signalytic Uganda. I'd like to begin by, that's not how I meant to begin, but the presentation is ongoing as planned. I think we might need to just carry along. Great. This is a list of maternal deaths recorded over a 6-month period in Bale Regional Referral Hospital. And what we found was that the common cause of death of these 27 young women was a stockout of essential medicines at the facility. And as difficult as it is to accept, this is the stark reality across the Ugandan healthcare system. And this is what drives our team, to try to understand the pain point and see the opportunities that exist in that system. We set out to research these problems, especially in the lower health facilities, and discovered 4 key pillars that are required to have a successful digital system. These are software, hardware, connectivity, and power. And any failure along these pillars would result in failed digital systems. To better understand this, let's see how interconnected the healthcare supply chain is. We see that at the lower level health facilities, stock status information cannot be directly communicated to the correct databases. We also see that HMIS data is not available, or if it is incomplete. And we know that over 90% of the 6,000 healthcare facilities do not report data. We see that DHO supervision is limited because it's predominantly conducted through in-person visits or hearsay. And the EMR systems that exist are computer-based. The infrastructure for that doesn't exist, especially at the lower level health facilities. And lastly, the powerful ERPs, such as the NMS and GMS, are starved of the data they need to see of the consumption data they need. So all these problems, as we showed earlier, contribute to the challenge that we're trying to solve. Our solution is to build an integrated technology stack that combines human-centered software design principles, relies on low-cost hardware, is resilient to network outages, and also relies on renewable energy. And a combination of these allow us to create a solution that is flawless in how it functions, and ultimately it can function anywhere we install it. Okay, so what does the platform look like? The platform is a health information stream box that streams health information data all the way to the lower level health facilities, where a health worker can access ministry-sanctioned digital tools to report data, and also it's solar powered and is drilled into the wall to ensure it's safe and secure. Our blockchain technology allows information to be shared across facilities so that we have clear stock status information. When the slides come back, we'll see what this solution looks like in a moment. Let's give it any moment now. Apologize for the disruption. Okay. I think we'll have to catch up, and if we have a chance at the end, I would gladly run through the slides. What our system is capable of doing is that by being installed at the lower level health facilities, a local Wi-Fi signal is created from which the installed systems can communicate to a handheld Android tablet. The health facility is presented with the HRMS compliant store manager application that we use to capture stock statuses and do community digitization at these facilities. And all this information is available at the DHO in real time, so they can perform medicine management in a way that with manual systems hasn't been possible. With data bridges that are built into the system design, we can write this information to central warehouses like NMS through our distributed ledger technology, as well as the HMIS systems that exist and DHIS2 as an example. The future state of this system has our game changer box installed, especially at the lower level health facilities, where the mobile tablet we provide has an app store experience to it, where any ministry sanctioned application can be installed to it remotely, right? And as our system also relies on can create a local network to allow it to speak with IoT-enabled devices. So anything from drone technology, and being able to speak with other medical services, this would be a big bonus to it. At the same time, we would engage the private sector, such as pharmacies, to have our systems installed in these communities so that they can extend more of those patient care services closer to the people. Brilliant. Okay, so this is what I've tried to describe. Okay, now, okay, no worries. So what we're capable of seeing with our system is that through this interconnection of all facilities and every player participating on the network, we can now rely on digital contracts that funders can rely on to disburse money through our system based on verifiable activity or KPIs. And this is made possible through the end-to-end visibility of our solution. Okay, so how do we achieve this future state? We start out by scaling. To get into all the 6,000 health facilities across the country, we build a local supply, local assembly line that is context specific to the needs of our environment. We hire local technicians that we find in these environments and are capable of servicing solar panels, servicing the solutions, the boxes. And lastly, we build data bridges. These bridges are what allow our system to speak with other higher level stakeholder databases. For sustainability, which is important, we want to end the reliance on donor support. And the first step to that is to widen our installation base across the country. This is an important point, but how we intend to approach this is by having the donor community purchase our solution as a replacement of the budget lines that exist, where they would rely on traditional hardware such as computers and desktops that have failed to take off in these environments with limited infrastructure. Our solution is cheaper than any comparable technology. Step 2 to this would be to develop public-private partnerships with the warehouses. And lastly, I would rely on market-based revenues, where for the transactions that happen through the system, we charge a small but fair share for the value realized. To date, we've had traction in Kiliandongo, where we've seen the solution adopted quite well, and we continue to expand to Masaka and Kalangala as we try to test and confirm these results. We would also like an impact evaluation report published to just show the efficacy of the system with an independent researcher. The initial results indicate that despite the poor infrastructure in Kiliandongo, we're seeing 100% system uptime because we rely on renewable energy and have good networking infrastructure there. And at the same time, we've been able to see very low, what we call data efficient transactions of projected to be 5 megabytes a year, which is almost 1,000 times lower than what's currently budgeted for alternative solutions concerning the data they need. Ask for funds as I conclude is to build out the assembly line so we can build local, hire local, and as well as build these data bridges required to make sure our system is integrated fully in the sanctioned applications. And finally, this is our team. This is our team that is experienced. We have technologists, myself, we have impact evaluators and also for the deep medical background to just guide the vision and allow us to achieve the digital future we hope for. Thank you. Okay. I welcome any questions from the judges. Thank you.
Thank you very much for that presentation. I'll jump right in because I know we're trying to manage time. The question around getting donors, or I'm not sure if I heard you well to say to get them to buy some of the equipment to keep the facilities engaged. You may, because you see, we're talking about donor independence, and then we're saying, but first buy for us the equipment. It might be a bit of a mismatch. Maybe you can consider the facility, have you considered maybe the facilities having skin in the game and asking them through a payment plan or, you know, leasing or some other model that is not really sort of negating what you've just said about donor independence? Over.
This question is probably unfair coming to you first, but I noticed some of the most of the solutions we've seen, and including yours, is largely relying on tablets. One of the challenges that we've had with trying to digitize in the health sector is the misuse of hardware. You buy a laptop or a tab, and you find it in a doctor's home, or there's a son out there attending a Zoom class. How do you picture the safety of these tools once we deploy them? Thank you.
Thank you, Team Signality. I think you bring out innovations around the pain points for digital systems around internet, power, software, and hardware. The question I have is around integration with the other facility management systems. You talk about integration with DHIS2. As you're aware, there is systems that MOH has approved for managing commodities in the store. So how do you then position your system in regard to the other systems that are approved? Your presentation was a bit silent also on the aspect of management of commodities outside of the store in terms of traceability to the patient. Do you intend to also expand in that light? And then lastly, of course, the aspect of positioning information to the DHO is nice with the dashboard. Do you also see yourselves working to also expand the system to kind of talk to aspects related to adverse drug reactions? That's key. I think you haven't talked to that as well, but mainly around integration with facility management information systems, and if you're going to explore aspects relating to traceability to the patient, that would be key aspects that you have not touched. Thank you very much.
Thank you, Analytic. I think this is I like the idea of using renewable energy. That's really environmentally friendly. I was just worried about the issue of costs, because you said the cost for 3 points of service was about $1,900. I don't know, the 3 points of service may also differ if it's a big facility or if it's a small facility. So it's not very clear if each facility has 1 point of service. But also, I'm worried about the issue of security, and also for the other innovations we've seen, the issue of security. How do you hope to handle that?
Maybe I'll just add to that question as well, because mine was linked to the cost as well. If you could help us unpack the cost of a unit box. I think you mentioned if it's scaled up to multiple facilities and either to be produced locally, serviced locally, are those parts local? But I like the element of local technology and local technicians. But if you could help us unpack the cost of a single unit, a box, so we could also determine or give us insight on the scalability in terms of cost. Okay. Thank you.
Great. Okay. Thank you.
I have a small question on ownership. You can clarify. Are you building the system from within or you have imported it from somewhere? Because we are looking into local solutions for our local problems. Thank you.
Great. Thank you so much for the engagement. I can tell from the questions. I'll happily run through these with the time we have. Our understanding is that the current climate we live in is heavily supported by external donors. And so in order to prevent a potential replication or wastage of existing budget lines, we think that it does make sense to ask for the replacement of inappropriate technology that current donors are thinking of rolling out, even if we know that there are infrastructure challenges across the country, which is why we make the case for approaching those donors and making the case for having our systems. So concerning theft, kindly help navigate to slide 10 or 9. Slide 9 shows that the system is actually drilled into the wall, and we do that because we understand the environment here could be challenging security-wise. And this tablet as well has an enclosure that allows it to not be moved without permission, essentially locking down the system to the wall. That's our approach to security. The other about misuse, as you can see from the tablet, if you can't see at the tablet, it's a completely locked and shielded environment. We do not allow installing unsanctioned applications to the tablet. So once it moves away from the facility, it's a brick. Won't do anything for you. It's designed not to be misused because we understand, again, the environment we live in. Concerning integration, yes, we are thinking, we've designed the system to speak with other systems such as the EMR. Kindly move to slide 11. Slide 11 and run through them shows that through the data bridges, as we keep going, I think 2 more activities, everything stored on the distributed ledger through our data bridge is communicated to the central warehouse. And this is where we lean in and call for support from consortium players such as yourselves to provide that momentum for us to build these data bridges. We do not intend to replicate anything that exists. We only intend to have a solution fill in the infrastructure gaps that we are all aware of, and then allow the ministry-sanctioned applications such as RX Lite, if it comes to that, or Drug Dash, or other innovative applications to be instantaneously made available to the facility. The cost slide, kindly slide 14. And we did have all this in the deck, but the technical challenges prevented us from showing this clearly. Okay, to understand the unit pricing, the box you saw plugged into the wall, along with the initial tablet, is $1,500. The key differentiator and the ability to scale is that for every additional point of care we have, it only costs $200. So if you needed 10 points of care, it would be incredibly cheaper than the current, than having to purchase 10 laptops or 10 desktops. So there are immense cost saving. And each of these boxes can support up to 5 points of care. And that's how that's why we believe that our cost per unit is quite scalable. Concerning ownership, number one, all the data on this distributed ledger is stored in country across the different facilities and DHOs. Wherever there is a box, they work as a node. So the ownership of this is whoever has the encryption keys. In this case, it would be the Ministry of Health or these applications that are sanctioned. The boxes are sold as is, and we would charge a support fee and also work with implementing partners to see how to maintain these systems down the line. Okay. All right. Thank you very much for the audience. Really appreciate it.
Thank you so much, Elvis. Let's give them a better round of applause given the technical challenges. Let's have the next team, ACCare.
Kindly allow me remove this mask, please. Good morning, ladies and gentlemen. My name is Joseph Mulabi, founder and team leader at ACCare. Where I come from, when it comes to delivery of medical supplies and products, is a problem. As a matter of fact, before I left, we used to spend an entire year without seeing an ambulance. We realize that when there is a challenge of medical supplies emergency or need, ambulances, for example, where the medical products are found, to reach our remote areas, they take too long. And this is just because of the poor road network. In our villages, those remote areas, there is no access to internet. And also the healthcare providers do not have access to digital devices like we are here in town. So we realize that when you deploy ambulances to take medical supplies in these remote areas, of course, they spend a lot of time, and also there is resource wasted, and yet we believe that the demand is very huge, but supply of medical products is very low. The contributing factors are, of course, there is shortages of stock, shortages of availability of products. We take an example of blood, but also we realize that Ministry of Health, NMS, and other implementing partners in the supply chain also do not have information about stockouts. Therefore, at ACCare, we are innovating around the deployment of drones. Drones run at a speed of 100 kilometers per hour, and they are able to cover a distance of about 127 kilometers. And actually, one drone is able to take on about 50 deliveries on a daily. This is, first of all, cheaper compared to ambulances, because today you will need to fuel an ambulance, you will need a driver, and of course, all that is time wasting. But when it comes to deployment of drones, all a health worker, all they have to do is to call our center. They will use toll-free calls. We shall also use USSD codes, but also be able to provide a way where they can be able to send emails, but also through social media to be able to contact our call center, and we have the medical supplies delivered to them. We believe that through this, we shall be able to improve the services of the supply chain handlers. For example, if for example, a health facility ordered or wants blood, they are able to call our center, and we connect with the blood bank, and we shall have blood delivered in the health facility in the shortest time possible. And we are looking at being able to deliver medical supplies within 45 minutes. You realize that today, very many women, pregnant women, die in hospitals. Actually, annually, over 2,000 women die because of postpartum hemorrhage. Children who are anemic also die due to lack of blood, accident victims, those who undergo surgeries. So we are able to liaise or partner with the blood banks across the country to be able to sensitize the communities and the general public using celebrities, using key public figures to be able to have enough supply of products, for instance, blood, because blood is essential and yet supply is very low. We believe that when we do this, we shall be able to save lives, we shall be able to cut down on the costs, and we shall be able to make easy the work of our partners, for example, Ministry of Health, blood banks, and other partners in the supply chain. We believe that our system, being a delivery system, is very easy to man because it doesn't require any use of or deployment of, for example, ambulances today. You need the fuel, you need the driver, and someone else in there to transport these medical products. But hey, what happens when a patient is in, for example, Kalangala? These people rely on ferries actually to be able to take drugs there. But this is all time wasting and it leads to death. Now, our plan eventually is to be able to deploy drones in Kalangala for our pilot and be able to impact over 50,000 lives, be able to save over 5,000 women, children, accident victims, and probably those who undergo surgeries with available medical supplies, but also be able to work with over 20 health facilities in that area before we scale up. Now, towards our scaling up, our vision is to be able to deploy drone delivery services in every regional hospital in Uganda, so that when there is a need for deliveries, this person calls our call center and we are able to communicate with the regional center, and we have deliveries made quickly to where they are needed. Using drones, ladies and gentlemen, as I said, is cheaper, and through this we can actually save more lives, save on the costs, and be able to provide adequate services. Thank you. That is all I had to say. Our team, we are a team of innovators. We are a team of innovators. We have entrepreneurs, business development entrepreneurs, ICT, and together we come to save lives. Thank you very much.
Thank you so much. Let's get a round of inquiries from the judges.
Thank you. Your name changed in the course of the presentation, so I don't know how to address you. Here, they say paramedic and Lifeline, right? Wonderful presentation. Mine is mainly on the technology side. And allow me, normally we use these buzzwords, robust, but now I'll use the word robust in the sense that how adaptable is this technology in terms of weather? There's an element of temperature control in terms of the products you're going to. Will you be able to fly or launch this hardware or equipment on a rainy day? So is it? Then the other one is maybe you expand on us on how many launch pads do you have around the country? That's in terms of risk. So in the event that one launch pad station is not functional at that material moment, you can still get deliveries made from an alternate facility. So those are the two lenses on adaptability and weather, and then the risk component.
Can I be able to answer question by question?
We'll take all, then you answer at once.
I'll add on to that. I know that drones are not yet permitted in this country. They are security sensitive things. That's number one. How do we make a security sensitive operation really be beneficial? Particularly looking at the most critical population, the mothers and the children. And then number two, the weight of the commodity that a drone can carry. Is it really cost efficient and cost effective to use drone technology to move commodities for a health facility which has, for instance, 20 or 5 mothers who need care or blood? Can a drone really carry about 5 kilograms? Because 5 liters is equivalent to 5 kilograms. That's very unlikely that it can be able to carry 5 kilograms of blood in terms of weight.
Thank you, Care. I like the idea the innovation, new, it's not very clear how affordable this strategy is. If you can just clarify and let it.
Thank you. Thank you. How are you planning to link in with existing government side infrastructure in terms of ensuring that we don't duplicate or step on each other's toes? Because it's a nice innovation, but I think it links into what some of the previous speakers were saying about security and risk, that how are you leveraging the government structures to enable you to jump through some of those hoops?
Thank you very much, Team ArcCare. So I think mine is in relation to complementing an already functional supply chain. So I think we need to kind of think through your value proposition. You can't use drone technology to provide all essential medicines and health supplies. So basically, you want to provide things that are critical, emergency, few units of blood, oxytocin, probably that if you send by car, it will reach when the patient has died. Maybe vaccine, ultra cold, you may have a few units if that's the best way. But also trying to look at where in this country would this be best placed, where topography is bad. Bukwo, Kapchora, maybe, and Kalangala would be kind of the best place to put that. And lastly, you may also consider kind of tying this up with the already existing public health emergency nodes, where already there exists some structure and system, so that you can log into their already existing information systems to be able to kind of get your stock status, where do you get these items from, and so on and so forth. Thank you. Otherwise, good innovation, we just need to contextualize it to complement a system that should already be able to meet most of the supply chain needs. But these are kind of emergencies that over and above the response requirements is in seconds rather than hours, if I would say. Thank you very much.
Thank you.
All right, so before you...
Yes, I wanted to know if this range of 120 kilometers is one way.
One way.
So what are the possibilities of, if I land there, like, does it run on fuel? Does it run on solar? How will it be operated on the other side? But what I wanted to know, because like we've seen similar innovations offered to us with a better payload of up to around 25 kilograms to carry. This one seems rather low, but I'm wondering what are the opportunities for the security services running this? Because I know in some of the countries around you, near Uganda, where they have security concerns just like us, the drones are operated by the security services. So is this something you've explored? What did you find out?
Yeah, thank you. The ability to transport emergency commodities must be linked to a system that can track where those emergency commodities are. We've seen it over the last few weeks as we are responding to the emergencies related COVID. Sometimes you had to call 20 or 30 health facilities for you to be able to know which hospital has oxygen. I think for value proposition, it would be very important if you link it to the network. Say if you're talking about blood, we should be able to link it to all the blood banks and know which blood bank actually has blood. If you're talking about district hospitals, if you link your system to a system, the blood bank system, and you can tell at a given point that Lugazi Hospital has blood. So if there is an emergency near Ginger, probably you can pick blood from there. Instead of first making phone calls to 5 or 10 or 20 hospitals to find out which blood bank actually has oxygen. And I think that would make a lot of actually sense moving forward. And people would be attracted to that because you are linking actually two systems. Thank you.
Thank you.
Thank you.
Okay, very, very good innovation, particularly if it's tuned to handling emergencies. Just one issue, the cost of course, of running drones is very expensive. And so who pays is something you need to think about, because you may get this money, but who will pay for the deliveries is something that needs to be thought about. It may not certainly come from here. But also linkages with other institutions like national medical stores, which has the mandate to supply all public sector facilities. It would be good to think about that if you're able to go through, but also the private sector.
All right, so thank you so much, Judges.
Thank you.
I want to share one more question from the online community.
Okay.
And most of the questions are really around the weather and the topography of the areas like Kasese, Kapchora. How will you be able to ensure that deliveries are made to those places? And then secondly, could you talk about how these, at health facility level, how will this technology handle redistributions?
Thank you. Allow me start from down. The cost of drone is expensive. According to our research, actually, deploying drones is cheaper compared to deploying motorbikes. And that's why we had to merge DroneMedic and LifeLink, because LifeLink was actually looking at deploying specially customized motorbikes to be able to transport emergency medical supplies. But we realized that when we go for motorbikes, it will be more expensive compared to deploying a drone. A drone does not need a driver. It will run by itself just from the command center using GPS, and it will be able to deliver medical supplies. I would also like to clarify, the cargo weight is not actually 6 kilograms. There are drones today. This particular one is made from Rwanda. They're using these drones already for medical supplies throughout the country. But this drone is able to carry between 10 and 21 kilograms of cargo. Also, we're not going to work alone. This program to work, or this project to work, we shall be able to link with the national medical stores, of course, the Ministry of Health, blood banks, in order to have, because we shall not be stocking products, we shall be getting them from these already established entities in order to be able to deliver them to health facilities. How does it run? Is it on solar? No. This drone uses a battery which is able to actually last for over 24 hours. So that makes it easy to be deployed actually on several occasions. As I said, it can be deployed 50 times a day, just one drone. The other question was, of course, linking with already existing structures. That's why I said we shall be working with the already established structures to get the products to where they are needed. But also affordability. All we shall be charging is between $5 to $10 for only delivery of the supplies. Regarding it with the current ambulances, there is protocol that must be observed, as I said, from fueling the vehicle to the driver, and then getting there with our poor roads. That is time consuming. So we shall be able to only charge for delivery of commodities. That is, we shall be charging between $5 to $10, depending on the distance where we are supposed to deliver. As I say, weight, I've talked about it, that it is not 6. That was a mistake. The other thing was the weather. And then, of course, the launch, the delivery centers. This drone is actually designed to withstand any weather condition. Be it rain or sunshine, hot or cold, this drone is able to maneuver through and get the products delivered to where they are supposed to be delivered. And I said that after like 2-3 years, we shall be able to launch delivery centers at every regional hospital. That means we shall be working with the regional hospitals to be able to provide medical supplies to remote health facilities. So we shall have, of course, our center, whereby if someone calls in, we are able to easily connect with the regional center, and then our team at the regional center are able to deliver the products right there. The other point was environment, Bob, the online question. I've talked about that. So our plan, ladies and gentlemen, is to have these drones actually deployed. In our first year, we are looking at Kalangala, as I said, but within 2 years, we shall be able to go beyond Kalangala, probably in over 10 districts in Uganda, and be able to empower and impact more lives. I hope I have answered all the questions. Thank you very much. Oh, security, yes. Thank you very much. Now, we've already actually initiated talks with the Ministry of Defense because there is no way we can run a drone delivery service platform in Uganda without clearance from security. So we've already initiated talks, and there is actually a positive response that we shall be able to run these services. Maybe, Bob, just in a second. Eventually, we shall be able to establish a website that will provide data, because in remote areas, you're talking about mobile apps, you're talking about tablets, but even accessing to a keypad phone is a problem. So we shall be able to actually collect their data in a paper form, feed it in already established established platforms that are linked to NMS, Ministry of Health, so that they are able to get information in real time and make right decisions on delivery of medical service supplies in remote areas.
Thank you so much.
Thank you for listening.
Let's give them a round of applause. Dokuta, you're up next. Your time starts now.
Good afternoon. Allow me to remove my mask. I'm Wes Judd. I'm the co-founder Source Code Technologies and also Doctor Product Lead. Doctor is a VHT stock refill system. In Uganda, most vulnerable families, especially those ones in hard-to-reach areas, and with pregnant mothers and children under the age of 5 years, when they get any complications, the first point of contact, they are VHTs. But when they go to the VHTs and they find no drugs, they have to move to the health facilities, which are in more than 5 kilometers. And those are the big numbers we are seeing at the health facilities. The major problem, the VHTs, is stockouts. We made a research and we found that the stockouts are because of the poor record keeping at the VHTs. Currently, they are using paper-based tools, and when it comes to the decision making at the supplying health facilities, it's very hard because they don't know the consumption in the community. So that is data visibility. So these VHTs are now relying on the word of mouth to be updated on any information from up. So because of that, we are losing 336 maternal deaths per 100 live births. So the VHTs are the foundation of public health services, and they are helping in linking the communities to the health facilities. So our solution is a data-driven mobile-enabled platform, which enables the VHTs in ordering, managing the stock, dispensing, following up on the patients, and also doing referrals. Then also the system does automatic reporting at the end of the month. So at the health facilities, they're able to do, we have the web application, which is installed at the health facilities, and we have the resupply calculators, which determine how the quantity for every commodity for these VHTs, basing on the consumption and stock on hand. So they have information required in making evidence-based decisions, then in planning and accountability. So what we are currently, we have achieved that, but what we are looking at next is doing redistribution. We found some VHTs run out of stock, others you find them with overstock. So we want to enable stock sharing. Then we want to scale to private sector. You know, currently there is a private sector, private public partnership, mostly for differentiated drugs for HIV patients and family planning. So how this private sector will be using the doctor, they receive stock from the supplying facilities. They are able to enter that stock. Supplying this facility. That is also that's also one. The other existing systems that we are out with the last number of distribution. When you go to the villages, you find like some of these tests. So as Dr. Uga said, patients captured some of the dispensers and also how that's what I'm looking. They are looking at national violence that's for police. Yeah. Get this function this and fly so that that's bias. But sustainability, we are looking at say without the savings and so that we can sustain our work. We also look at open questions. So how we can open questions. What they do open then we want now patients to then we are looking at the quality data. Then also reduction. So our mission is taking virtual this is how it works. We have steps for us. Our insights.
Thank you so much. Thank you very much for that presentation. Just Barry, the private manage the national code, certificating the product from a public facility. Guys,
That's one. Two, also what we're trying to do is supply. By the time we get redistricted, either don't pass not something upstream. So the idea is greater. So we understand that why would it take the Yes.
for the development of data. But from some of the assessments that have been done, the biggest driver of these stockouts is actually stockout at the facilities that we stock in them. So we can make the journey there, but they find nothing to come home. So how did, because I don't, because that is so thing, describe now that stock information mentioned. How do you refer the problem? Yeah, where it is, and those stock out, and where the stock be out. So we have these thank you for the presentation. President of the excellent. Also, yeah. And you realize that the health facilities, they are at the center, the operations of that. So they will need the data, the fields, they will need the data, the reporting, it's after this operation. And I think, how do you activate the role of the health facility?
Sessions. So first, I'll start with the one from independence partners. How we're going to so currently it's a public-private partnership. So the government is pushing for that, and what we want to know is the government is saying some those private sectors. Most of those ones don't interconnect so we want to build on that. We don't find it's just for pharmacists, so it's social interactions and those things. So we are looking into building that works in villages. Then still on that we want to see whether it's possible to supply the 6 ways in just like these PhDs. But we've also gone ahead to see that it is possible to have like a champion PhD in a district with more mass. So there becomes a cost. This. Then data storage and security. So currently we are still because we are that's what we are doing. Data partnerships so that we can get on post that data. So, but for us, what we've done on the terms of security, we are using the encryption methods so that we have the data being transferred in the safer way. Then stockouts at the health facilities. So we believe once the health facilities are able to get the consumption information or the data from the health facilities, then they'll be able to store.
Your time is up. Thank you so much. Let's give them a round of applause. The same spirit, I want to appreciate our online community, very active, organized presence. I think the questions and comments coming in will ensure that get respond to them. Let's have the next team, track mate. Start now.
Good afternoon, ladies and gentlemen. Good afternoon, ladies and gentlemen. Good afternoon. My name is Jerry, and I'm representing the team at Frontmate. I'm a senior 6 student in the I think the volume is good. So at Frontmate, we have 2 key value propositions. We are providing real-time data on the deliveries of medical goods. We are enabling traceability of essential medicines to the patient. This is very critical. Many of the electronic reporting systems around, they currently don't address this need. And TrackMate is an innovation from medical electronics. The primary entity in our innovation is the QR code or the quick response code. So, what's the problem? Currently, in the medical logistics system in Uganda, we have a challenge of poor tracking and accountability of medical supplies. National medical stores faces much difficulty in tracking medical supplies to those centers. Only about 40% of those centers are reporting back data on medical deliveries. Most of this data is not high quality and it's not real time. This makes effective decision making hard because we're just making decisions on proxy data and there are lots of estimation. There has been quite a lot of but we want to supplement on what KNMS Plus is doing by providing a cheap solution that can complement and even get integrated into that system. The main problem is you can't track the flexibility of medical deliveries down to the end patient and the various health centers. So even joint medical store faces similar challenges in NFS. So, next slide. So, where do the opportunities lie? So, by innovating with QR codes, we can provide a cost-effective solution because QR codes are very easy to generate. We are solving the problem of poor accessibility and accountability in medical logistics by providing a cheap, easy to deploy way to help NLS track the deliveries of medicines to governmental standards. Now, our system can also be used to monitor the deliveries of free medicines, vaccine, and contraceptives from government warehouses to private clinics. Now, the key entity we are harnessing in our technology is the mobile phone. Now, here we have a statistic according to the National Household Survey 2019-2020. We have a very high mobile phone penetration in the country. So our mission at TrackConnect is to provide a cost-effective solution to track medical deliveries by national medical stores down to the health center, and we can also track delivery of drugs to the inpatient, especially essential medicines. Yeah, so how it works. We use custom software to generate QR codes and we print them on stickers. We put these stickers on batches of medical codes which are going to be sent to various health centers. So in a QR code, we can encrypt information and send out these antibiotics that are going to the health center. So when this batch of drugs reaches there, the logistics officer at that health center uses their smartphone to scan the QR code. Now, in the app permissions, we have access to the geolocation. So on the dashboard, the DHO can actually ensure that the drugs actually reached the health center. So that's how we achieve our first value proposition. We track delivery of drugs to the health center. Now, how drugs have actually reached the patient? So a different version of this custom QR software generates a QR code and we print it on a card and we assign a customized card to each patient. When the patients are registering in this system, we verify the identity using a national ID. So whenever they go to the health center and they receive their drugs, the dispensary officer scans the QR code and that ensures that they've actually received the drugs in the electronic system. So the market size, we have the public sector and the private sector. So the private sector is critical because that's how we are going to make the whole process sustainable. The money we get from that is what will be used to cover the costs. So we can sell this to supermarkets and factories. So differentiation, our system is easy to use. There is no specialized training. Scanning QR codes is very easy. It's also very cheap to implement. So the roadmap will generate the QR codes, will generate the QR codes, will develop the mobile app, will get tech support from NMS and NITAU to integrate with the existing infrastructure, will track medical deliveries, and will make everything customized. So the revenue model, one-off sales, subscription services are not very successful in Uganda. So the things we'll need are basically smartphones. We'll probably not need to buy these because the phone penetration in the country is high. We'll need printers for generating the QR codes and the QR code stickers and the QR code cards. So what we are asking for is $10,000 to pilot this. We haven't tested it out. It's still at the ideation stage. We'll need tech support for hosting our database, so NITAU servers that will ensure the whole system is safe, so no cybersecurity concerns. We'll need laptops for developing the software, and we'll need some printers. So that's our team, very experienced at writing code. Thank you.
Thank you so much, Eric.
Yes. Yes.
In terms of hoarding essential medicines or supplies, which we can send to the private sector.
Yes,
Because if
that's
I'm in the
very
private sector, I
Yes.
don't want to be involved in filling in all these forms
Yes.
and be burdened with filling public forms. Yet they must be filled. So if I'm used as a conduit to create demand and satisfy demand for free medicines, particularly vaccines, family planning commodities, can the QR code have all the components which at issuance of the drug, once I click it out, it will capture the issuance data and report it back to the supporting health facility, for lack of a better word. Say if we associated all health facilities to private clinics, so the health facility, the public health facility is responsible for providing the commodity for the private health facility. Once the QR code is clicked, it automatically updates the logistics management information data in the store. Is that possible? Because that way I see it being seamlessly and easy to engage the public sector without them spending too much, but at the same time assisting us in getting the free medicines delivered to the community.
Dr. Eric, that is very possible because a QR code.
Okay. Eric, if I could go second, because I'm very impressed, first of all, by you. I wish I could go back to senior 6 and be like you. Then certainly this traceability of medical supplies is something very, very important for the country to help improve the quality that the user gets, of medicines that the user gets, but also to remove issues around fake and counterfeit medicines. And so this is really good. And I like that it can be integrated across sectors. You've asked for costs for installation of the printers. How else are you going to be remunerated? You'll be paid for what is printed, and so how much is a QR code, say, for per product?
I can go next. I want to thank you very much for taking interest in supply chain. I imagine that you did your due diligence and you know the volume of health supplies that is moving around within the supply chain value chain. At what point are we going to scan this QR code? Is it at the warehouse, at the factory, or at the health facility? Thank you.
Thank you, Eric and team. I think good innovation around commodity traceability. My addition to the rest of the other judges is just to mention that commodity traceability is more of a challenge once it has reached the facility going to the patient. I think the part that comes from the warehouse to the facility, really the challenges are minimal. So in terms of refocusing your innovation, I think it would be prudent for you to focus the part that the patient now needs to get the commodity, whether all commodities that got received are actually dispensed to the patient. And I think the innovation of the QR code specifically would be a good one for commodities that are packed in bulk packs like ART, probably anti-TBs, where you issue full packs to the patient. And again, that would be very helpful, as Dr. Eric said, once you scan the QR code, you should be able to proceed and complete the accountability processes, subtract, reduce stock, and all that. What's kind of not clear is you talked about the patient also scanning. And I think from the patient side, although you mentioned that coverage of phones is at 74%, I think majority of that could be the analog phones. The smartphones from the patient side may really be a small proportion of that. So I think your innovation is good, but you need to tweak it to do with more
traceability and accountability to the patient. And then the idea of making sure that this is linked up to existing systems already. So you may explore actually having some handheld devices that connect to already existing systems at the facility, where the scanning is going to help improve the speed of dispensing at the facility or in the community. And I think that would be a niche that would be really an important one. Thank you very much.
Thank you, Eric. I had some questions for you, but they've been asked by the Commissioner and Dennis. I just want to reaffirm what Dennis said, that I applaud you. I mean, I could never do that presentation 30 years ago. So, and I wish in terms of a problem you're solving, I think Paul here from National Medical Stores is having sleepless nights on how he's going to track the COVID vaccine that is coming through. So if this solution was here today, I'm sure. So it's not an endorsement, but I applaud you the thinking and the idea. So there's a great opportunity in this, and good job.
Thank you very much. So I'm going to try and address the numerous questions. One was about getting free medicines from government facilities to private clinics. This is very possible because in the QR code, you can store quite a lot of information. That's why in industry, there's been a push to move from barcodes to QR codes, because QR codes are more data intensive, and even if 30% of the QR code gets damaged, it's still scannable. So that's very possible, especially for free medicines, vaccines, and contraceptives. Another concern was about patients having smartphones. The patients don't need the smartphones because once they've got that custom QR code printed on a card and they go to a dispensary officer, the dispensary officer gives them their medicine, then they remove the card from their pocket, and it's the dispensary office at that clinic that scans the QR code. So the patient only has a card with the QR code, doesn't need to own the smartphone as per se. Another question was about the costs involved with generating QR codes. Practically, it's almost zero apart from maybe hiring the IT staff and having the printer there. Because like the same way you can have a printer and you print like a Word document, is the same way you generate the QR code. So the only investment is the software end. The same ordinary printer can work. So in terms of like, there is no special cost for generating the QR code, and on a normal A4 size paper, you can have quite very many QR codes, even about a grid of 24. So the costs there are quite low. Then another question was about the two value propositions which our project is addressing. One, we are tracking medical deliveries from the warehouse to the health facility, and we are tracking medicines at the health facility to ensure they reach the patient. A concern has been addressed that what's most vital and what's most needed is the second value proposition, ensuring that medicine reaches the patient. The first one is being mostly solved by NMS Plus, and we agree with that mentality. So we'll gear our innovation towards that end. There was a concern about integration into existing systems. Once we have the system fully running, we can develop an API, and that information is picked from the API, and it goes into government databases. So we can fully integrate into the existing IT infrastructure for the Ministry of Health and NMS. Thank you.
A round of applause. Thank you so much, Eric. Let's have the team flow. You have a question?
Question as such.
30 seconds.
But there have to be costs, because also the printing costs are costs, the material to print, also distribution costs. So if you're to go through, you need to elaborate that.
So yes, there are costs.
Eric, take that as feedback. You'll work on that. For any business that you run, there are costs involved, maybe paying rent, paying staff. That's what he's referring to. The team at Pulse Medical, a local manufacturer of medical lab reagents. Good afternoon, ladies and gentlemen. Randekere Polycarp is my name. I'm here to present Pulse Medical Logistics. So everyone has gone to a hospital before and been sent to a laboratory. So in the lab, sometimes those who have gone to government hospitals, at least once or twice you've not had a test because there were no reagents. Or if you've gone to a private hospital and the test is going to be done, it's been expensive. So at Pulse, we aim to solve that problem. We realize NMS reports say there is constant stockouts. Even right here, everyone is talking about stockouts in hospitals. What we came up with is we realize the cost of the reagents has reduced the quantities that NMS can buy using their allocated budget. But in our assessment, we realize these are reagents which can be made locally, and that's why we came up with a solution to produce these reagents locally. The best opportunity we have is these reagents can be made, the technology to make them is available, plus we can get the raw materials, plus we have most of these reagents are mainly made of water. About 80 to 90% is water, most of them. So what we are importing mostly is bulk water. So what we are proposing is a solution of producing the reagents locally, which will reduce the importation time because it takes more than 4 weeks to import a container by sea, or plus reduce the cost of importation because if you fly these things, they're going to be expensive eventually to the end user. So our innovation comes in not at the upstream, but at the downstream. Our innovation feeds into the warehouses, not the patient side, but we follow up our items up to the patient to check functionality, quality. That's where we get the final answer, whether we're doing the right thing or not. So our mission is to provide local solutions to the global laboratory supplies, but at international standards, and to enable availability and affordability. So that will help the stockouts issue where the budget is limited. Then we'll have bigger quantities for these same items, or we have saved budget and then it can be used for something else. That will be helping the budgeting people, the quantification teams, and the national allocation bits. So how it works is most of these reagents are made of water. Yes, I told you that, but the formulations are available and they are international. They're available on the open forums, open source platforms. Well, it's not we even taught these things at school, composition and how to make them, how long to incubate and do stuff. So our position is to acquire the standard formulations. Where we cannot get of locally, we'll have to import where it's available, then process these chemicals and package them, and then deliver to distributors, local distributors available, or the warehouses, which is NMS, JMS, medical access, who will eventually deliver to the the end user, the hospitals and clinics. Our market size is almost all hospitals in Uganda have a laboratory at least. Health center 2 upwards should have a laboratory. So our clients will be everyone, private, government. That is what we aim at achieving. So we're not producing one type. We in the end we intend to have everyone. So we have about more than 5,000 government and PNFP facilities, and about more than 1,000 private health facilities in Uganda, and this is a good market for us. So the differentiation is we have quick access. The imported versions have take some time to get here, like we told you, importation time. The cost of goods will be, our goods will be, from our initial analysis, they'll be a bit cheaper. And the financial burden to the distributors. Also, this will help in growing the scientific line of people. Every year, universities graduate about, we have graduations about maybe more than 400, or about 1,000 students in sciences, both medical sciences, artisanship, engineers, all these we need to use to work with in our field. The channels of distribution will be through the existing ones, national medical stores, JMS, those are our first distributors. Then through the distributors who are already here, the local distributors for the different items and the different manufacturers. The others are marketing mixes and how to follow up for feedback. From our analysis, our production was always, the cost of raw materials is about a quarter of what they are sold at. So we have a very big gap too. So if you have a 25% as the cost of production, at the eventual price, the final price, adding amenities and whatever and the stuff, I don't think we'll get to more about, to the current price, we'll have about 50 to 70% the cost, current cost of what you're buying if we produce it locally. Our traction so far, we've done a prototype phase, we've seen how the formulas work, we know they work. So we are looking at, we have identified the sources of raw materials, we know equipment needed for the packaging materials, equipment needed to make the machine, the reagents, and the formulas have been tested. So we are okay with our traction, we are sure these things work. So the roadmap is we intend to have a minimum viable product in the next, by December, the setup should be done, and we have a product at least to show you, the sponsors. And then begin certification processes by March, and development, and then acquisition of more investors to expand by mid-year. By end of the year, we should have a product running, so that by next year we are already set up. By 2023, we are set up, ready to run a big production for the bigger production, not just a few products. And then we'll have diversification coming up also. So the leadership team is they were all Ugandans, and we're here. So our ask is that if we got the 50%, the 50,000, we would have so many things to use it for. But whatever figure we get, we have an allocation for it as we add up to get to the final figure. Thank you very much.
Thank you, Polycarp. Let's get inquiries from our panel quickly. Whoever is ready, take it.
Thank you, Pulse Medical. For me, I think this is really good. It's in the direction that the world is going to get local production into our country. My only worry, what I would have loved to see is that if you had mentioned one or two gadgets that you're already working on, so that you can tell us what the cost benefits of these would be for consumers. But,
more questions from the online community. Are all the raw materials available locally, or do we still rely on exports for some of the inputs?
Can I answer this? Respond? Yes, please. I didn't get your name. Dennis. Dennis. Mr. Dennis. Sorry. I think I went beyond. Sorry. I'm doing it so fast. Okay. There is a diagram. There's a graph I want to show him. The next, just back a bit. So we did, there's a few reagents we piloted, and this was hematology reagents, if you know medicine. So diluent, a lyse, and a cleaner are basic reagents used on hematology platforms. Everyone goes to the hospital. This is a screening test usually done. Almost everyone should have gone through this, should have had this test in their lifetime. And the basic, and the costing is, yes. For example, you see the diluent up there. Our production cost of raw materials only is $12, but the current cost is about $58, $60 average cost. So we have 12 for production. We haven't added the rest is costs of running around, basically logistics of running the company. But the cost of raw materials is 12. So we have, that's the 25% of the current cost. So we have all this big gap of about 75% of the cost to play around with to come to our final pricing. So we don't think we'll have a big difference. The raw materials, about the raw materials, some of the raw materials are available, while most of them will be imported. But the cost of importing 2 kilograms of a powder is not the same as the cost of importing 4 tons. Oh, no, I mean, maybe 4 containers, 4 40-foot containers, which can be produced by the same 2 kilograms of powder. So the cost difference comes in the terms of importation and time taken to produce these things when required locally. How we get, I didn't get your question just again. Yes, distribution, we talked about, there are already existing distributors here, but this is an arrangement that has to be made with NMS. If NMS wants us to deliver from the factory to the end user, that can be arranged, and that is possible because yes, the double handling is a problem and it leads to mismanagement. So once we have this thing done running, it is very possible. As long as we get a call of order to deliver to so and so, it should be possible.
Thank you. Impulse made, just to add, normally, of course, the proposition is that once things are produced locally, they are cheaper. Doesn't always work out that way. So I think you need to be able to balance your throughput, how much you're going to produce vis-a-vis the market to make sure that the cost of labor, cost of electricity, and the cost of manufacture doesn't really outweigh your value proposition. So that needs to be carefully balanced. The other one, of course, is you need to begin with a carefully selected range of the products. And I think there's opportunities for laboratory products that have really short shelf life at manufacture, like those expert ultra reagents and so on. So starting with those that actually lose more than 50% of their shelf life before they even reach here would be very important to make sure that facilities really receive stock that is of good shelf life. And then I think lastly, there's a global trend towards laboratory tests being kind of managed by the equipment manufacturers, where you now do a contract and charge per test. So again, you may need to seek strategic partnerships such that in that trend, you are in that value change, where you benefit by being their local agent, producing these things locally. And of course, you also still don't get wiped out when now the contracts are being charged, kind of made with the equipment manufacturers and is done per test, kind of going towards equipment hire and so on and so forth. So you need to be kind of cognizant of that trend. Otherwise, good proposition, as the other members have said. Thank you very much.
Thank you, Kidi. About the short shelf life reagents, yes, from our experience, these are more technically challenging to make, but our proposition is to start with the less technical things and then advance. Those come in our diversification once we've set up, and those will come in and we will be able to see how best we can adapt to that. Thank you very much.
Right. Thank you so much. A round of applause to Polycarp. Biogenics, you're up next. Your time starts now.
Good afternoon, everyone. My name is Tony Hasasha. I'm a medical doctor by profession, and I'm the CEO of Biogenics Limited, a local company that manufactures PPEs, to be specific, K95 masks and 3-ply masks. So when COVID struck, that is around late 2019, it affected globally the health supply chain, affected businesses, and a number of other sectors. Uganda was not spared, and by around Feb, March of 2020, we were facing a crisis on our hands. One of the things that were noted was a shortage in supply of masks, particularly KN and medical masks. And of course, the president was talking about it. I, being a medical doctor, bore part of the brunt because we were seeing shortage and we were trying to innovate. And I said, wait a minute, we are scientists, that's why we are here. So we decided that we are going to do something about it. And so we went about to design a machine. Because of cost of production, we did make a design of our own machine and imported a few critical components, and the rest we made. And you know what happened? Voila, it worked. And this is one of our products. This is produced locally here. This is our KN95 mask from that machine. We have a license for it from the National Drug Authority. This is the quality. And of course, we are also licensed by UNBS to do that work. So the problem that we are trying to address is shortages in supply of PPEs. And of course, this leads to stock out downstream. And the solution we are providing is local production upstream in the supply chain, and we think this is very, very critical. It guarantees stable supply, it guarantees stabilized prices, and of course it will reduce on costs. Our objective is to ensure consistent supply. We are targeting to produce 125,000 masks. We are focusing on the medical mask 3-ply because 90% of the masks used are this particular one. Both in the medical sector and even in the general public. So I want to focus on it. 125,000 pieces daily. Currently, we are producing 65,000 pieces daily, and we think we can double if we have the grant. The second proposition we want to make is on pricing. The current going rate for wholesale is about 160 shillings per mask, makes it about 8,000 shillings per box. We want to drop that cost to 110 shillings per mask. Those are the two propositions, and that is going to ensure, number one, stability of supply, number two, affordability, which are critical in the supply chain. As the do go on. One will ask, how do you want to do that? I wish my PPT would be up, I would show you. But there is a critical component. That mask that you're putting on, the 3-ply, even the KN95, has the most critical component, and that is the melt-blown layer. That is what filters, that is what does the magic. It is a static filter, and it also is a major cost driver. It costs $4 landed to bring a kilo of that, and that translates to a cost of 11.3 shillings per mask. So making it locally here can drop that cost from 11.3 to about 5. So that is one thing we want to do. We want to manufacture locally this particular component. It is not being made in East Africa. Even the other manufacturers import it, and that's a risk to our supply chain. So if we are to do something and stabilize, we need to make that locally. It will drop the cost and guarantee stability. The second thing that we want to do, of course, is increase on production, and that means we also do the most critical part. What really informs numbers is putting the ear loop. The machine that makes that frame of the mask produces about 350,000 pieces per day. But the rate limiting factor is putting the ear loop. So we want to get another ear loop machine, and that will enable us double our production rate to about 125,000. Those are the two things we want to do. And for that, we are asking 50,000 shillings to start production of the melt blown layer, and number 2, to scale on current production. Our channels through the distributors, general stores. We supply to Abacus, which actually is a supplier to NMS. So in a way we get there. We also supply to a number of other distributor pharmacies, but we have been pre-qualified by joint medical stores, and now we're just finalizing on price point. We also do vendor managed inventory, and we deliver to some hospitals, like in Zambia Hospital, like City Medicals, like Cure Hospital in Mbale, and a number of other units. We believe that because we are local producers and we are licensed, we have an NDA license and UNBS, we are partners worth working with. How do we ensure sustainability? We produce the mask at 70 shillings. We sell it at 110 shillings. That is about 40 shillings. This translates to about $36,725 per month if we are to produce at the current rate of 125,000 pieces. If we do this, we think that we'll have sufficient revenue to guarantee our other performances and also to ensure that we grow. We have other things that we are thinking about. In the next 3 to 6 months, we want to address this, and that's why we need this funding. In 1 year, we want to start production of rapid antigen tests, COVID kits, malaria, HIV. We already have the knowledge, the expertise, and the ability to do it. We will just need to factor in funding for that over 1 year. And in the next 2 years, we hope also to produce gauze and cotton. In short, biogenics is the ultimate solution for the upstream production of supplies like masks, like rapid tests, like gauze and other things. Our team is composed of about 5 people, myself, and we have an able team that is able to deliver that value. So thank you very much for listening to me. I welcome any questions.
Thank you so much. Let's get in questions from our panel or inquiries.
My mic isn't, oh, it's okay. Thank you very much. It's a very encouraging innovation to be able to know that we can have this capacity Quick question in terms of your ask, because you're saying that right now you can make the mask, you just want to get this inner layer and this loop to be able to scale up. Is it because you're not able to make the ear loops fast enough? I wasn't clear on what the challenge was there. And the melt blown layer, just for information, can it be used for anything else apart from the mask? Just so get some context. Thank you.
I want relatedly. I mean, right now masks are big because of the COVID. It's a pandemic. I mean, it's an epidemic. Probably in the next 2-3 years, it's going to cease to be an epidemic. I'm just wondering how often or how critical are these nature of masks important in terms of addressing the sustainable development goals or for use in the medical? I know they have use, but how critical if it wasn't for the pandemic, and how is it easy for you to transfer the technology for producing products that you have now, which is maybe used to respond to an emergency, to a normal situation where you will be able to convert that and respond to the usual maternal child health required commodities during a period where there are no epidemics?
Thank you. Very good and timely innovation for the country. My issue is around how you're going to work to ensure that these cost savings you have made from the 160 shillings to 110, that they are passed on to the final consumer. Are you having discussions with other stakeholders? Because we know we all buy these at 1,000 on the market. So you could have that, you could be able to reduce your cost, but then the consumer still pays the same.
Okay. Yes, I just wanted to highlight how you plan to mitigate risk associated with the global supply chain disruption in the event that the component you want to import doesn't come. Thank you.
Thank you. Let me just put a point I think it would be important for you to think about it. We've seen that, especially in the current context, the demand is quite very high. And even for some of the commodities produced locally. So the local production does not necessarily translate into price reductions because there are so many price regulatory mechanisms, issues beyond your control. And maybe for the learning purposes, what have you been able to learn from some of the locally produced commodities, and how have they been able to kind of work towards price regulation? And I think the latest example is the COVID-19. Okay. So what is the learning, and what is that learning that you are trying to incorporate into your innovation? Thank you very much. I will start with the first question that was about the ear loop and the melt blown, and how that fits into scale. Unfortunately, she stepped out, but the ear loop and the melt blown are components. We are still producing masks with them. This is a mask made by us, what I'm wearing. However, we import the melt blown. What we want to do is to manufacture the melt blown here, because for all the manufacturers, they are importing. Even in Kenya, they do import. So we want to be able to manufacture the melt blown, which is the most critical component. And that's one of the things we want to do to ensure stability. If I can answer the second last question about mitigating risk in disruptions in the global supply chain. One of the things is to produce the items locally, or the necessary raw materials locally. And so we want to be able to produce the melt blown locally so that at least we are cushioned, because the rest, if the worst came to the worst, you can use any string for a mask, but the melt blown can't be replaced. So we want to do that as an innovation. Can the melt blown be used for something else? Yes, that same technology or that same machine is what you find in filters for example, car filters, because it is an electrostatic filter. So you'll find it in other filters that are used in various items. So yes, the melt blown can be used. They asked about the sustainability. Dr. Eric asked about the sustainability. Just to give you some stats, pre-COVID, the consumption of masks in Uganda was about 132 million pieces per year. And most of it, 100% was being imported. When COVID came, that almost tripled. We went to about 300 million pieces at the peak and then dropped, and the market stabilized at about 265 million pieces currently. So even with COVID going away, there is a big market. But secondly, the machine that we made that produces this is exactly the same. You only change dyes and it produces pads for the ladies and for women. So it can be repurposed, and there is what we call SMED, the single minute estimated change of dye. You can transition from making this to making pads with 30 minutes. 30 minutes. I can transition from making K95 with the same machine. I change the dye to making pads. So it is sustainable, both because there was a market and because we can. Let me just
quickly, your time is up, but also someone online is inquiring why you and not any other manufacturer. Why should they consider you and not any other manufacturer of the same product?
Because currently, first of all, nobody makes the melt blown. We want to make it. They haven't come up to make it. So definitely that makes us stand out. Secondly, we are quite innovative. We have a number of other products that can be transitioned from this to other products. Other manufacturers haven't. Third is that even with all the combined local production, about 50% is still being imported. So there is a big need. There is a big need. That's why I believe biogenics needs to get this funding, because we are rightly positioned to address a very great need. Thank you so much for listening in. My time is up. I haven't gotten to answer the question of what we have learned in the pricing, but we have learned at least one thing, that when there is no local production, the price shoots. The box actually went up to 200,000. Currently is going for 10, but it went up to 200,000. This time we still saw a spike because of the demand when the second wave came, but it wasn't as high. We predict there is a third wave. There's an article in New Vision that was published, I think, last Friday, and the third wave is expected around February. So there is going to be another need, and I think that's why our innovation is timely. Thank you so much for listening, and God bless you.
Thank you so much. Let's have the team from Blood Alarm System and our final innovators for the day.
Yes, good afternoon. I'm Lugolovi Philip, a medical student from Makerere. I'm the founder of the Blood Alarm System. So, frequent blood stockouts in health facilities have always been a challenge in the country, despite a significant increase in the amount of blood collected. For example, the EBTS almost hit its target in 2019, but the blood stockouts were still rampant. Why this discrepancy? So there is inappropriate blood use. A recent study showed that transfusions to 55.5% of anemic children are inappropriate, with totally no indication in 16.3% of cases, clearly indicating that health workers do not follow transfusion guidelines. Also, this leads to artificial blood stockouts in which preferential use of blood over units of a particular blood group resulting to their stockouts. This is common with blood group O. There is also, health facilities also experience blood stockouts without the regional blood banks knowing, and the process of ordering for blood is a lengthy one. So there are blood bank management systems which can try to solve these problems, but they are very expensive. One has been in use by the Uganda Blood Transfusion Service for several years, but we have never realized its full potential. So the resulting blood stockouts in health facilities have greatly contributed to the poor health indicators in our country. So the blood alarm system is our solution, which accurately quantifies the health facilities' minimum blood requirements, monitors stock use in real time, and automatically notify the regional blood bank about pending blood stockouts. In monitoring stock use, the system ensures accountability and traceability of blood and its components, supports appropriate use of blood, hence efficiency of blood use. The system is easy to use and cheap, and our target beneficiaries are health facilities registered with the UBTS, the Ministry of Health, and partners. Our mission is to ensure the availability of blood and its components to the right patients by providing data to accurately quantify the minimum blood requirements of health facilities, monitor blood stock in real time, notify the regional blood banks about pending blood shortages at these health facilities, and support appropriate blood use by health workers. So the system consists of a simple hardware piece attached on a blood refrigerator in a health facility registered with the UBTS, and a server at Nitayu, whose information can be accessed by the regional blood bank. Information flow between the regional blood bank and the health facilities bi-directional. The system can switch to SMS encoded messages in case of poor internet connection. The system is to be integrated with the blood bank management system in use by the UBTS, and the interface and the hardware piece has been designed in a way to support compliance to existing blood transfusion guidelines prior to accessing blood. So at the start, we are targeting all the regional blood banks in the country and the health facilities registered with the UBTS, but in the future, we are to target health facilities which need blood for smooth operations, and these are mainly private health facilities. So the blood alarm system at worst is equal to the eDelphine, which is the blood bank management system in use, the HMIS UBTS forms, and the bedside transfusion forms in all those categories, and interestingly at a cost-effective manner. So we have to spend on the hardware pieces, a monthly data and SMS bundles to enable the hardware piece to run smoothly. Administrative costs which involve repairing the hardware pieces in the field, training users at health facilities and EBTS on how to use the system, research and development. The system is to use Nitayu server, so there is no need to buy a server. The hardware pieces are going to be given for free to the health facilities once the system rolls out. And then the revenues from monthly subscriptions for the service by the health facility and the regional blood bank. The cost of the hardware piece and its installation will be offset within a year and a half. We have a prototype already. The project was selected by the Africa Oxford Innovation Platform for support. We have identified local companies to help us fine-tune the hardware and the software bit. Ebiton company, which is an original equipment manufacturer, and the UBTS, a key a key slide. The EBTS, which is a key partner in our pilot. So our roadmap in the next 4 months, we are to refine our prototype, the hardware and the software, and then followed by 10 months of the pilot phase involving intense research and development before rolling out the system in early 2023. So we seek funds to refine our prototype and pilot the system. Then we are a great team of students from Makerere University with a technical and business background. Yes, we have our simple budget and so those are my teammates, and that's our simple budget. Thank you.
Thank you so much, Phil. Let's get questions or inquiries from the panel.
Thank you, Philip and team, for the good innovation around blood. Indeed, blood is a key aspect that has been talked about in almost all the maternal child health technical working groups in terms of data. Can we get the data visible? And I think this is an attempt to provide that data that is being looked out for. My question is the system basically limited to just blood? Are you also going to incorporate the other products that normally go with management of blood at the blood bank, in terms of the collection bags and all the other things that will be required, so that the demand generation, the demand side is also taken care of, like picking the blood itself, as well as the side that you're looking out for the management and issuing and rational use of the blood. Number two, of course, is the value proposition that you've made. It still has an element of annual, maybe one-off payment, and then the aspect of the monthly subscriptions. That may be unsustainable. You may need to rethink and rework it to what best fits a public sector approach, or maybe differentiate your public sector proposition from the private sector proposition, such that you're also looking at the common good, which actually we are trying to address with all these system strengthening interventions. I think the last one from me is, I'm not sure whether you talked about integration with other platforms like DHIS2. I think there's already blood as a tracer product among the 42. So I think this would be very helpful in providing that stock status as you expand to the facility side. Otherwise, great innovation that solves the need that is current. But of course, these are the things that I thought you would think through as you plan to scale up your innovation. Thank you very much.
Thank you. I think this is a very good innovation. What I kept asking myself as you presented is who will own this? Will it be with you, or it's going to be integrated within the public system? In terms of data, of course, security, but also ownership of the information that you have.
Okay, thank you so much for the questions. So starting with the blood collection bit, as I projected in my first slide, the donor management task force is really doing a great job.
in collecting blood, but they are also relying on okay, their efforts are driven by the blood bank management system. And then I've said that our system is going to be integrated with the blood bank management system, and the real-time information about the demand will really guide the efforts of the donor management task force. Okay, that is it involves the teams which move around collecting blood, so they will be able to know that they are stockouts, send SMSs to donors, and then go on and pick blood. And then a bit about the business model and the sustainability of the project, we came up with a matrix comparing a one-time pay business model and the subscription model. And then we found out that it will be very costly for the government to install the system if we are to adopt the one-time pay model. For example, the hardware piece, which is to be given out for free, will have to be sold at around $350 for the startup to make profit. And if there are about 200 health facilities, that brings it close to $70,000 for the government to install that system. And then about the maintenance of the system, it is very difficult for under the one-time pay model, because it is upon the hospital, the health facility administration to buy data, SMS bundles, and repair the hardware pieces in case they break down. And the lobbying process is a lengthy one, okay, in health facilities. But with the subscription model, these are all covered in the monthly subscription, and the company will swiftly correct any issues arising. And then the question about integration. Yes, I said that the system is to be integrated with the blood bank management software system. And also we are going to use the information from the DHIS2 to train our machine learning algorithm, which is also important in estimating the blood requirements for the health facilities. Then about the ownership of the information, to overcome the risks of breaching the Data Privacy and Protection Act, we are making sure that this information is held or is owned by the government. That's why our information is going to be hosted by NITAU. Any more questions?
Are you good? Maybe let me just check if you have any from the online community. Thank you so much. We don't have any. Thank you for your presentation. A round of applause to the team. So we've come to the end of the pitches. A round of applause to all the innovators. So what comes next? We're going to have the judges step out. Please follow Belinda to the plenary. And that's where you'll be deliberating from to choose who our top 3 winners are for the day. And then the rest of the team, please follow Sheila and Bridget. We're going to have a photo moment. And after that, we shall return where they will declare the results and we'll go for lunch. So judges, please follow Belinda to the plenary. And the rest of the team, I will follow Sheila and Bridget for the photo moment. And for our online community, we'll catch up with you in a moment when we return.
about pending blood shortages before actual stockouts. We believe the system will improve accountability and traceability of blood and its components. Thank you.
With the advent of the COVID-19 pandemic, there's great scarcity of PPEs, especially surgical masks and K95 masks. Hi, my name is Dr. Tony Hasasha from Biogenics, the manufacturers of K95 and surgical masks. A problem we are trying to address is stock out of PPEs, especially masks, at health centers and other medical facilities where they are needed. Our solution is an integrated two-way solution of both manufacturing locally and delivery within 24 hours at the point of need. We believe that with this two-pronged solution, stockouts should be a bygone and an issue of the past. Thank you so much, and please support Biogenics in this great cause.
Currently in Uganda, the pregnant mothers and the children under the age of 5 years, they get their treatment, or whenever they get emergencies, their first point of contact are the community health workers or VHTs. But there is a big problem when they go there and there is no medicine. Source Code Technologies will come up with a platform which helps these community health workers in requesting for these commodities in real time anywhere. The system also supports them in sending the monthly reports of the consumption of these commodities.
Why does it take long for medicine, vaccines, drugs, and other medical supplies to reach remote areas around Uganda? My name is Irad Nahamia, and at Bromedic, my team and I have come up with a solution. We would like to ease your agony by airlifting these medicines and medical supplies using drones from our central district to remote areas in your area to reach health facilities to help you save lives and at the same time cheapen the cost. Thank you.
If you've been watching the news, you've seen multiple reports of health facilities running out of things like gloves, ARVs, or medicines and vaccines. Support system, which sits at the health facilities, collects this information and presents it in an easy to consume format so that the people who make these decisions can make them in a timely manner to ensure that the facilities have the requirements that they need.
You've all gone to a hospital and been sent to the laboratory, but then your test couldn't be carried out because they didn't have reagents. My name is Polycarp Randike. We came up with a solution to that. The solution is to produce and manufacture those reagents locally here such that they're available all the time. That will also make them cheaper and they'll be available when you need. Next time you go to the hospital and your tests are done on time, no pulse diagnostics, pulse logistics, all work together to make this solution available for you. Thank you.
We believe that a successful digital system has 4 key pillars: hardware, software, connectivity, and power. And a breakdown at any one of these pillars would result in a supply chain system that is fractured. Something that proves that a supply chain is only as strong as its weakest link. we've designed a fourth industrial revolution platform that runs off renewable energy at the lower level facilities to provide a key point of digitizing health facility information and also providing real-time visibility of that information upstream. We work with innovators, stakeholders to make these systems and software stack available, and we invite whoever is in the ecosystem to work and build off our platform. Thank you.
Currently, there is a major problem of bad traceability and accountability in the medical sector in Uganda. National expensive way. Thank you. Currently, there is a major problem of bad traceability and accountability in the medical sector in Uganda.
This is a major challenge in monitoring drug deliveries to health centers. They have tried to innovate on this problem by using the electronic reporting system, but this requires providing an internet connection at every health center and teaching and training health workers on how to use a computer. And for electronics, we've developed a technology called TrackMed system, which leverages the existing smartphone infrastructure while using QR codes to enable national medical stores to track medical deliveries in an inexpensive way. Thank you.
We realize upon experience and research that there is a problem of supply and logistics in Ugandan health facilities, especially when it comes to supply of blood. We are designing a mobile app that is going to help health workers be able to locate and book for blood easily. And we're also going to be advocating and sensitizing communities and the general public to donate blood. We are a team of qualified experts in technology, business development, and together we are aiming at saving lives through blood supply and the faster, secure logistics. Thank you.
The blood alarm system is the solution to the problem of frequent blood stockouts in health facilities all over the country. The system works by establishing the minimum blood requirements of a health facility, enable the regional blood bank monitor the availability of blood in real time, and notify it about pending blood shortages before actual stockouts. We believe the system will improve accountability and traceability of blood and its components. Thank you.
With the advent of the COVID-19 pandemic, there's great scarcity of PPEs, especially surgical masks and K95 masks. Hi, my name is Dr. Tony Hasasha from Biogenics, the manufacturers of K95 and surgical masks. A problem we are trying to address is stock out of PPEs, especially masks, at health centers and other medical facilities where they are needed. Our solution is an integrated two-way solution of both manufacturing locally and delivery within 24 hours at the point of need. We believe that with this two-pronged solution, stockouts should be a bygone and an issue of the past. Thank you so much, and please support Biogenics in this great cause.
currently in Uganda, the pregnant mothers and the children under the age of 5 years, they get their treatment, or whenever they get emergencies, their first point of contact are the community health workers, or VHTs. But there is a big problem when they go there and there is no medicine. Source Code Technologies will come up with a platform which helps these community health workers in requesting for these commodities in real time anywhere. The system also supports them in sending the monthly reports of the consumption of these commodities.
Why does it take long for medicine, vaccines, drugs, and other medical supplies to reach remote areas around Uganda? My name is Irad Nahamia, and at Dromedi, my team and I have come up with a solution. We would like to ease your agony by airlifting these medicines and medical supplies using drones from our central district to remote areas in your area to reach health facilities to help you save lives and at the same time cheapen the cost. Thank you.
If you've been watching the news, you've seen multiple reports of health facilities running out of things like gloves, ARVs, or medicines and vaccines. Research has shown that this is because these facilities don't have enough timely and accurate information to make the necessary interventions. Drug Dash, therefore, is a decision support system which sits at the health facilities, collects this information and presents it in an easy to consume format so that the people who make these decisions can make them in a timely manner to ensure that the facilities have the requirements that they need.
You've all gone to a hospital and been sent to the laboratory, but then the test couldn't be carried out because they didn't have reagents. My name is Polycarp Rwandike. We came up with a solution to that. The solution is to produce and manufacture those reagents locally here, such that they're available all the time. That will also make them cheaper, and they'll be available when you need. Next time you go to the hospital and your tests are done on time, no pulse diagnostics, pulse logistics, all work together to make this solution available for you. Thank you.
We believe that a successful digital system has 4 key pillars: hardware, software, connectivity, and power. And a breakdown at any one of these pillars would result in a supply chain system that is fractured. Something that proves that a supply chain is only as strong as its weakest link. We've designed a 4th industrial revolution platform that runs off renewable energy at the lower level facilities to provide a key point of digitizing health facility information and also providing real-time visibility of that information upstream. We work with innovators, stakeholders to make these systems and software stack available, and we invite whoever is in the ecosystem to work and build off our platform. Thank you.
We realize upon experience and research that there is a problem of supply and logistics in the Ugandan health facilities, especially when it comes to supply of blood. We are designing a mobile app that is going to help health workers be able to locate and book for blood easily. And we're also going to be advocating and sensitizing communities and the general public to donate blood. We are a team of qualified experts in technology, business development, and together we are aiming at saving lives through blood supply and the faster, secure logistics. Thank you.
The blood alarm system is the solution to the problem of frequent blood stockouts in health facilities all over the country. The system works by establishing the minimum blood requirements of a health facility, enable the regional blood bank monitor the availability of blood in real time, and notify it about pending blood shortages before actual stockouts. We believe the system will improve accountability and traceability of blood and its components. Thank you.
With the advent of the COVID-19 pandemic, there's great scarcity of PPEs, especially surgical masks and K95 masks. Hi, my name is Dr. Tony Hasasha from Biogenics, the manufacturers of K95 and surgical masks. A problem we are trying to address is stock out of PPEs, especially masks, at health centers and other medical facilities where they are needed. Our solution is an integrated two-way solution of both manufacturing locally and delivery within 24 hours at the point of need. We believe that with this two-pronged solution, stockouts should be a bygone and an issue of the past. Thank you so much, and please support Biogenics in this great cause.
Currently in Uganda, the pregnant mothers and the children under the age of 5 years, they get their treatment, or whenever they get emergencies, their first point of contact are the community health workers or VHTs. But there is a big problem when they go there and there is no medicine. Source Code Technologies, you've come up with a platform which helps these community health workers in requesting for these commodities in real time anywhere. The system also supports them in sending the monthly reports of the consumption of these commodities.
Hello, everyone. So a quick announcement. For the winning teams, you're going to get plaques or plaques,
Why does
whatever
it
they're
take long
called.
for medicine,
And
vaccines,
the communication I'm
drugs,
getting
and
is
other
that the
medical
plaques don't
supplies
have
to
the
reach
team names yet for the
remote
winning
areas
teams.
around Uganda?
So when you get them,
My
you
name
take
is
photos
Mamia,
and
and
return
to
them
Medi, my
so
team
that
and
we
I
can
have
have
come
the
up with a
technical
solution.
team
We would
print
like to
the
ease
winning names
your
of the
agony
teams on them.
by airlifting these medicines and medical supplies using drones from our central district to remote areas in your area to reach health facilities to help you save lives and at the same time cheapen the cost. Thank you.
If you've been watching the news, you've seen multiple reports of health facilities running out of things like gloves, ARVs, or medicines and vaccines. Research has shown that this is because these facilities don't have enough timely and accurate information to make the necessary interventions. Drug Dash, therefore, is a decision support system which sits at the health facilities, collects this information, and presents it in an easy-to-consume format so that the people who make these decisions can make them in a timely manner to ensure that the facilities have the requirements that they need.
You've all gone to a hospital and been sent to the laboratory, but then the test couldn't be carried out because they didn't have reagents. My name is Polycarp Randekeye. We came up with a solution to that. The solution is to produce and manufacture those reagents locally here such that they're available all the time. That will also make them cheaper and they'll be available when you need. Next time you go to the hospital and your tests are done on time, no pulse diagnostics, pulse logistics, all work together to make this solution available for you. Thank you.
We believe that a successful digital system has 4 key pillars: hardware, software, connectivity, and power. And a breakdown at any one of these pillars would result in a supply chain system that is fractured. Something that proves that a supply chain is only as strong as its weakest link. We've designed a 4th industrial revolution platform that runs off renewable energy at the lower level facilities to provide a key point of digitizing health facility information and also providing real-time visibility of that information upstream. We work with innovators, stakeholders to make these systems and software stack available, and we invite whoever is in the ecosystem to work and build off our platform. Thank you.
Currently, there is a major problem of bad traceability and accountability in the medical sector in Uganda. National Medical Stores faces a major challenge in monitoring drug deliveries to health centers. They have tried to innovate on this problem by using the electronic reporting system, but this requires providing an internet connection at every health center and teaching and training health workers on how to use a computer. At Erico Electronics, we've developed a technology called TrackMed system, which leverages the existing smartphone infrastructure while using QR codes to enable national medical stores to track medical deliveries in an inexpensive way. Thank you. Currently, there is a major problem of bad traceability and accountability in the medical sector in Uganda. National Medical Stores faces a major challenge in monitoring drug deliveries to health centers. They have tried to innovate on this problem by using the electronic reporting system, but this requires providing an internet connection at every health center and teaching and training health workers on how to use a computer. At Erico Electronics, we've developed a technology called TrackMed system, which leverages the existing smartphone infrastructure while using QR codes to enable national medical stores to track medical deliveries in an inexpensive way. Thank you.
We realize upon experience and research that there is a problem of supply and logistics in Ugandan health facilities, especially when it comes to supply of blood. We are designing a mobile app that is going to help health workers be able to locate and book for blood easily. And we're also going to be advocating and sensitizing communities and the general public to donate blood. We are a team of qualified experts in technology, business development, and together we are aiming at saving lives through blood supply and the faster, secure logistics. Thank you.
The blood alarm system is the solution to the problem of frequent blood stockouts in health facilities all over the country. The system works by establishing the minimum blood requirements of a health facility, enable the regional blood bank monitor the availability of blood in real time, and notify it about pending blood shortages before actual stockouts. We believe the system will improve accountability and traceability of blood and its components. Thank you.
With the advent of the COVID-19 pandemic, there's great scarcity of PPEs, especially surgical masks and K95 masks. Hi, my name is Dr. Tony Hasasha from Mangent, manufacturer of the K95 and surgical masks. A problem we are trying to address is stock out of PPEs, especially masks, at health centers and other medical facilities where they are needed. Our solution is an integrated two-way solution of both manufacturing locally and delivery within 24 hours at the point of need. We believe that with this two-pronged solution, stockouts should be a bygone and an issue of the past. Thank you so much, and please support biogenics in this great cause.
Currently in Uganda, the pregnant mothers and the children under the age of 5 years, they get their treatment, or whenever they get emergencies, their first point of contact are the community health workers or VHTs. But there is a big problem when they go there and there is no medicine. Source Code Technologies, we've come up with a platform which helps these community health workers in requesting for these commodities in real time anywhere. The system also supports them in sending the monthly reports of the consumption of these commodities.
Why does it take long for medicine, vaccines, drugs, and other medical supplies to reach remote areas around Uganda? My name is Irad Nahamia, and at Dromedic, my team and I have come up with a solution. We would like to ease your agony by airlifting these medicines and medical supplies using drones from our central district to remote areas in your area to reach health facilities to help you save lives and at the same time cheapen the cost. Thank you.
If you've been watching the news, you've seen multiple reports of health facilities running out of things like gloves, ARVs, or medicines and vaccines. Research has shown that this is because these facilities don't have enough timely and accurate information to make the necessary interventions. Drug Dash, therefore, is a decision support system
before actual stockouts. We believe the system will improve accountability and traceability of blood and its components. Thank you.
With the advent of the COVID-19 pandemic, there's great scarcity of PPEs, especially surgical masks and K95 masks. Hi, my name is Dr. Tony Hasasha from Biogenics, the manufacturers of K95 and surgical masks. A problem we are trying to address is stock out of PPEs, especially masks, at health centers and other medical facilities where they are needed. Our solution is an integrated two-way solution of both manufacturing locally and delivery within 24 hours at the point of need. We believe that with this two-pronged solution, stockouts should be a bygone and an issue of the past. Thank you so much, and please support Biogenics in this great cause.
Currently in Uganda, the pregnant mothers and the children under the age of 5 years, they get their treatment, or whenever they get emergencies, their first point of contact are the community health workers or VHTs. But there is a big problem when they go there and there is no medicine. Source Code Technologies will come up with a platform which helps these community health workers in requesting for these commodities in real time anywhere. The system also supports them in sending the monthly reports of the consumption of these commodities.
Why does it take long for medicine, vaccines, drugs, and other medical supplies to reach remote areas around Uganda? My name is Irad Nahamia, and at Bromedi, my team and I have come up with a solution. We would like to ease your agony by airlifting these medicines and medical supplies using drones from our central district to remote areas in your area to reach health facilities to help you save lives and at the same time cheapen the cost. Thank you.
If you've been watching the news, you've seen multiple reports of health facilities running out of things like gloves, ARVs, or medicines and vaccines. Research has shown that this is because these facilities don't have enough timely and accurate information to make the necessary interventions. Drug Dash, therefore, is a decision support system which sits at the health facilities, collects this information, and presents it in an easy-to-consume format so that the people who make these decisions can make them in a timely manner to ensure that the facilities have the requirements that they need.
You've all gone to a hospital and been sent to the laboratory, but then your test couldn't be carried out because they didn't have reagents. My name is Polycarp Rwandekeye. We came up with a solution to that. The solution is to produce and manufacture those reagents locally here such that they're available all the time. That will also make them cheaper and they'll be available when you need. Next time you go to the hospital and your tests are done on time, no pulse diagnostics, pulse logistics, all work together to make this solution available for you. Thank you.
We believe that a successful digital system has 4 key pillars: hardware, software, connectivity, and power. And a breakdown at any one of these pillars would result in a supply chain system that is fractured. Something that proves that a supply chain is only as strong as its weakest link. We've designed a 4th industrial revolution platform that runs off renewable energy at the lower level facilities to provide a key point of digitizing health facility information and also providing real-time visibility of that information upstream. We work with innovators, stakeholders to make these systems and software stack available. And we invite whoever is in the ecosystem to work and build off our platform. Thank you.
Currently, there is a major problem of bad traceability and accountability in the medical sector in Uganda. National Medical Stores faces a major challenge in monitoring drug deliveries to health centers. They have tried to innovate on this problem by using the electronic reporting system, but this requires providing an internet connection at every health center and teaching and training health workers on how to use a computer. And for electronics, we've developed a technology called TrackMed system, which leverages the existing smartphone infrastructure while using QR codes to enable national medical stores to track medical deliveries in an inexpensive way. Thank you. Currently, there is a major problem of bad traceability and accountability in the medical sector in Uganda. National Medical Stores faces a major challenge in monitoring drug deliveries to health centers. They have tried to innovate on this problem by using the electronic reporting system, but this requires providing an internet connection at every health center and teaching and training health workers on how to use a computer. And for electronics, we've developed a technology called TrackMed system, which leverages the existing smartphone infrastructure while using QR codes to enable national medical stores to track medical deliveries in an inexpensive way. Thank you.
We realize upon experience and research that there is a problem of supply and logistics in Ugandan health facilities, especially when it comes to supply of blood. We are designing a mobile app that is going to help health workers be able to locate and book for blood easily. And we're also going to be advocating and sensitizing communities and the general public to donate blood. We are a team of qualified experts in technology, business development, and together we are aiming at saving lives through blood supply and the faster, secure logistics. Thank you.
The blood alarm system is the solution to the problem of frequent blood stockouts in health facilities all over the country. The system works by establishing the minimum blood requirements of a health facility, enable the regional blood bank monitor the availability of blood in real time, and notify it about pending blood shortages before actual stockouts. We believe the system will improve accountability and traceability of blood and its components. Thank you.
With the advent of the COVID-19 pandemic, there's great scarcity of PPE.
Make sure that we get to listen to what you have to present. Once again, for those of you who might not know me, I'm Richard Zulu from Outbox. So we're going into the last part of our session. And what we are going to do is we are going to get some remarks from the judges in terms of what they liked, areas for improvement. We shall get that from Dr. Moses Walakira. Then thereafter, we shall have the announcements of the winning innovations from Mr. Paul Mbaka, Head DHI, Ministry of Health. And then lastly, we shall have closing remarks from our commissioner from the Ministry of Health, Ms. Neville Oteba. So Without further ado, let me invite Dr. Moses Walakira to give us some general remarks from the judges in terms of the process. Thank you.
Doesn't seem to be on. Check. Doesn't seem to be on. Yeah, thank you so much. First of all, I do appreciate the team that has brought us here. And it has been refreshing to have teams of various groups, the innovators that have presented their ideas today. I think for us as the judging team, it's an opportunity to learn what other people are thinking about some of the solutions to the critical problems of the country, and maybe for the team to appreciate the solutions or the ideas you've been proposing are not only ideas to solve small problems for at a household level or at a village level. You've been proposing ideas to solve problems at a national level. So I think that is already good enough, and it's already motivating that you've been coming up with ideas or solutions to solve challenges at a national level. We had a criteria that we've considered. This has been a well-structured process, and the judges have been using a standard criteria that we came up with to assess your performance. And I thought it is important for you to know exactly what the key considerations were. We are mainly looking at the problem, whether the problem is actually very important to the country. Here we've been discussing issues of the country, not issues of a household, a small household, a small village. So we are looking at how big the problem was and how important this problem is in terms of addressing the, in terms of being very critical or a key barrier to the supply chain system of the country. And in terms of solutions, we've been looking at elements of effectiveness and appropriateness of the idea or the solution to address the supply chain barrier or bottleneck at hand. And then in terms of the innovativeness, we've been looking at whether this solution can actually take a bold or an original approach to addressing the barrier at hand. We have also been looking at the aspect of the impact of the solution, whether this is a demonstrable, it has a demonstrable potential. And the last two key issues we've considered is the element of integration. We know that we have a vast supply chain management system, but also we have many other other critical or related systems. For example, we have the health management information system, we have the national logistics management information system. So we've been assessing how the solution or the idea you're proposing can easily be integrated into the existing systems and how you've been linking your idea to the existing systems, including elements of sustainability. And then the last key area of consideration is the demand and accountability. And here we've been looking at whether the solution or the idea can increase the community level awareness and looking at the different accountability mechanisms that you've been proposing. So those are some of the broader aspects that were under consideration. The elements of feasibility, practicability of the solution, but also looking at the timeline. I mean the timeline of the idea, how practical can it be implemented to address the solution at hand? Is this a solution that will take 10 years, or this is something that can be implemented within 6 months? Overall,
the team, the review team, or the judges believe that the 9 teams that have pitched their work today were all passionate, and all the ideas that you presented were very relevant. And we also believe that each idea can solve a big problem at hand. The last bit I need to mention, and which is very critical, we do appreciate the improvements that have happened. Some of you that participated in the boot camp events, you can agree with me that a lot of improvements have taken place from that time, with the ideas you had, what you presented, to what has actually happened now. So there are those improvements that have taken place, and we do acknowledge the work that you've put in to come up with these ideas. Members, I think I'm going to stop at this because there are so many other panelists that are going to give you the overall summary of the results. I was just giving a broader picture of what the findings are. And overall, as I'm leaving, I need to say that all the teams have come up with good ideas. The ideas are broad, and these ideas can further be worked on and get implemented to address the various challenges that we have in the supply chain system of the country. Thank you so much.
Thank you very much, Dr. Moses Walakira, for those very kind words. So that further ado, I want to invite Mr. Paul Mbaka lead us to give us news.
Thank all the competitors. Of course, you had the unfortunate task of participating in a final. And as you all know, by just participating in a final, you have the salt, you have what it takes. But unfortunately, there must be a ranking. The competition was very, very close. Of course, statisticians like to say human beings have big preferences. So the judges had different averages, but the one thing all of them demonstrated is that all the participants scored within a very close range, which means the solutions were really good. And we really hope to engage most of you, even after the ones we shall announce. As you probably know, you don't have to come first to win. Right? So you might, we shall be engaging most of you. So without any further ado, let me play. You know the MC called me Devil Paul. How did you call it? Yeah. Monster Paul. You said Monster Paul. Yeah. So just like the devil's advocate, they call it what? The devil's advocate in the Catholic Church, the man who announces either the good or the bad news. I'm going to announce the top 5 competitors, starting with the 5th or the second. So we categorize the participants as either runners up or the winners. So I'll start with the runners up. That is the number 5 and number 4. And maybe when I announce, you can quickly come up for just a handshake from the commissioner. So the second runners up was the blood alarm system.
Blood alarm system. Let's give them a hand clap. Well done, blood alarm system. It's been a journey. They are online. It's just him. Go and bow and
make it scientific.
Make it a scientific. Where's the photographer? The photographer is there, so just pose for a photo. Very quickly. Here is good. Here. It's projecting, so this can work. Yeah. So take a photo. Okay. Congratulations. Pose for a photo. Elbow.
The first runners up, or the number 4, drag dash.
Drag dash. Put a hand clap for drag dash. Drag dash. Well done, well done. It's been tough. Okay, elbow and pose for a photo there. Look at, where's the camera? Here. Okay. Well done.
All right. Now we're moving to the winner series. Number 3, biogenics. Biogenics.
Biogenics. You're in the top 3. Very well done. Well done.
Commissioner.
Okay.
Commissioner.
There's a plaque. There's a plaque for you that you can take home and put in your office. Commissioner, you can change it. No? Hey, actually, it's okay. Yeah. Very well done. Very well done. How do they close this thing?
Okay, please sanitize. Please sanitize.
Okay.
Number 2, Signalytics.
Here comes Signalytic. Signalytic, welcome to the competition. Thank you very much. You did well. That's why you're number 2. Next time, please struggle hard to be number 1. Okay.
Well done. Pose for your photo. Yeah.
Okay. Considering we've been sitting the whole day, in the spirit of energizing, let's stand up while we welcome our number 1.
Number 1.
TrackMed.
TrackMed system. Well done, TrackMed system. It's been a journey, but you made it. Anything is possible. Well done. Very well done. Congratulations.
Hello. How does it feel like? Look at the camera. You are most welcome.
It feels great.
This is TrackMed.
Yes,
Please tell us how you feel and what you are going to do with this award.
I'm very excited. I didn't think.
See it in your face.
I didn't really think I could win. I didn't really think that our team could win this supply chain challenge, because this was our first major attempt at a major competition.
Thank you very much. Please clap for TrackMed. Welcome aboard. We are going to work together to make sure that we develop this concept further and your dream comes to a reality, not only in your head, but also in the minds and the services that we are going to provide to Ugandans. Thank you very much.
Thank you very much, Commissioner.
Receive your plate. This is your year. DJ, up.
Yeah.
Somebody got the market this year. The money up in this. There is something that I this year must be better than last year. It's your year. You know this is your year. It's your year. Yeah. this is Maya. Because I'm taking to Maya. And this is Maya. Maya.
Thank you very much, Commissioner. Let me invite you up on stage, or you can even, wherever you choose, give opening, closing remarks. Give closing remarks. Commissioner wants.
Wow, it has been a great day, great moment, especially standing with the winner. I also believe that I will benefit from part of the check, but we shall discuss that one later. Congratulations, everyone. Congratulations, track made. Colleagues, this shows us that anything is possible and everything is possible. The criterion has already been shared, and we thank the judges, we thank the innovators. Please, another round of hand clap for the innovators. Without you, we would not be here. Thank you very much for taking time to do what you have done. It can only be better. This is our first attempt. I think in the next competition, we are going to get about 300, and you are going to be one of them still. Please work hard, make sure that you improve on your concept. All is not lost if you are not one of the first three. We are going to continue partnering with you to improve the concepts. One thing for sure which is known is that all your innovations are relevant and necessary, but we can only take 3 for now as we plan for many more in the near future. Thank you very, very much. Thank you, our sponsors. Thank you, the Secretariat, the hotel. Thank you, our partners, for this opportunity. The supply chain can only move to greater heights with this kind of innovation. This is one of the solutions that we have been looking for. Homemade, easy to manage, cost effective, and yet is supposed to make the supply chain, value chain more efficient and effective. Thank you very much for participating. Please take care, keep safe, so that we are able to meet here in the next competition. I want to take this special moment to congratulate TrackMate. When you come for a competition, you have 2 options. Either you're going to win or you're going to lose. So today is your day. Please take this opportunity. Take each and every comment that you have heard through this pitch camp and inbuild the recommendations into the system. We are not going to leave here alone. We are going to monitor progress on all of you, the 9, not only the 3. We are going to work together, monitor progress, and continue improving. For those who are not yet on the first 3, don't despair. As I said already, we are going to work together with the Department of Pharmaceuticals and Natural Medicines to see how you can be assisted. You never know, today the resource envelope is for 3 in case we get other partners who are interested in your innovation. You will be called upon and we strategize. Thank you very much. Thank you, our sponsors. Thank you, the judges, the Secretariat. You have done a wonderful job. Keep it up, and please plan early for the next one. Thank you very much. Our participants online, we value you very much. Next time, we hope we shall be together in the same hall. Thank you for being active. Thank you for giving us the opportunity. Please celebrate with us the winner. Trackmate. Oh, yeah. Without few remarks, I close this speech camp. Thank you.
Thank you very much. I can't add on to that. It's time for lunch. Top 3 winners, please come on stage. They want to take your photos with your plaques. The rest of us, make sure you have this little green card. You can head over to the restaurant. Thanks a lot. Judges, let's also stay for one photo.